My name's Louise Fay. I'm one of the, that's better. I'm one of the obstetricians here at the Royal Women's in the GP Shared Care antenatal clinic. We spoke at the updates this morning, so some of you have heard me already, and you weren't meant to be hearing me again, so I apologise. Wendy Hawke is just tied up in a ward round upstairs. Wendy is our clinical director in obstetrics. You probably have met her through other lines of work, either through O&G and Andrew Bissett. She took over from Andrew Bissett's last year. So just welcome everybody. Everyone's got a lot of information packs and a lot of people who are here this morning. Hopefully you got a lot out of the talks from May and Shelley. We've got a really good lineup this afternoon. And thanks to all of our speakers for giving up their time on a sunny Saturday afternoon. So we're going to start with Ezra's going to talk a little bit about what's new at the Royal. This is Antonia Shand, one of my colleagues, head of maternal fetal medicine, who's going to rope you into a lot of research. And we're going to have genetics first with Alan and Ron. Then Maddie, one of our gynaecologists, is going to talk about termination, and our termination service is available here at the Royal. Then our psych team are going to talk about drug and alcohol use and pregnancy, which is obviously a very important topic. And then our excellent perinatal mental health service, which we're very proud of, with Dr. Stone and Robbie, our wonderful perinatal midwife, are going to talk about mental health in our mental health services. So we should wrap up here at around 4:30 this afternoon. There is an email address which isn't on this, which Ezra or May will put up if you've got any questions following the meeting that you'd like to follow up after this afternoon session. Thanks and enjoy the afternoon. I'll hand you to Antonia.
Hello, everybody. I've just been roped in as well. I was not expecting to be standing here. I'm very well dressed, just like Louise's. So thank you. One of the things that I'm interested in is research, where obviously there are a lot of research initiatives happening in Australia to try and improve the care for a whole range of people. Out at the desk out there, we are recruiting for women and also clinicians about research. So I've got a QR code that I've been pushing on people because I want to know about what you do know and say about seatbelt use in pregnancy. So that's why I've really just taken the microphone, because I'm doing a research project. And there are also some brochures, various brochures out there about CMV infection and also about asthma. Vanessa Murphy's there about a study about asthma. So that's really why I'm here on my Saturday because I want something from you guys, which is to promote research so we can do things better. So I'm afraid both Louise and I won't be staying, but if you've got questions for us later on, then there's an email address that you can have questions. And obviously what you say in the future means what topics go on at later meetings. So just feel free to give your opinions about what you want to hear about in the future. Thank you.
Thanks, Antonia and Louise, for giving up time on your weekend to be here with us. So I'd like to start first of all with the acknowledgement of country. We'd like to acknowledge the Bidjigal people, who are the traditional custodians of the land on which we meet today. I would like to pay my respects to elders, both past and present, and extend that respect to any Aboriginal people here today. So good afternoon, everyone. Welcome again to the Obstetrics and Gynae update. My name's May. I'm a GP working at Bronte Family Doctors and one of the GP advisors for the Antenatal Shared Care program. Me and Shelley and Ezra and Zarin are all here today. So please come and chat to us if you have any feedback or want to chat more about the Antenatal Shared Care program. A quick bit of housekeeping. So bathrooms are located ground floor and also up on level 1. The fire exits are located down here on level 0. Please follow the staff in an event of an emergency. We request that all mobiles please be turned to silent mode or switched off. If you do need to take a call, please go to the foyer. And we ask that no food is to be eaten inside the lecture theatre, please. We're pleased to present a comprehensive program this afternoon. In the interest of keeping to time, we request that you reserve asking any questions till the end of the session, end of each presentation. And please keep in mind we have a lot of attendees here and also online. So if we could keep questions succinct and be mindful of others who wish to ask questions, that would be great. As Antonia mentioned, there will be the opportunity to email in questions after the session. We'll provide that at the end, but it's essentially the antenatal shared care intake email that we can share with you, or you could also contact Lauren or Queen in the antenatal officer at CESPN. I just want to also plug the evaluation survey. It is crucial that we get feedback to further improve these updates, and we actually really look through all of your topic suggestions, and that is exactly what we use to shape the topics that we will put forward for the November updates. So any topics that you guys want to see presented on in the next few updates, please put it in your evaluation survey reminder, and we do look at all of that. Today's session is RSCGP approved for 3 educational hours, and they're uploaded to a dashboard after the activity, and 6 antenatal shared care points will also be allocated. So without further ado, I'll introduce our first speaker, Dr. Ezra Malouf, who's presenting What's New at the Royal Women's. She works at Double Bay and is a fellow GP advisor to the Antenatal Shared Care Committee. Welcome, Dr. Malouf.
Hello, everybody. Happy Saturday. I'm waiting for my slides to come up very soon because these are not my slides, but we'll get there. That's okay. Someone's presenting on genetics and pregnancy today. It is not me, just so you're aware. I'm just going to talk about new stuff at the Royal Women's because there's lots of new stuff in the last 6 months that, okay, here's my slides. I say as if I've prepared them, but the hospital have prepared them, so they're accurate. So another acknowledgement of country. Obviously, we acknowledge the traditional owners and custodians of the land, and we pay our respects to ancestors and elders past and present. I might not do it again because we did it 40 seconds ago. Now, the biggest change which we talked about at the last update, in case you guys weren't here, is that the visits have changed. So in the past, the midwives would see them every month or so, and now between the booking, the Royal Hospital for Women's Midwives will see them at the booking visit, the 15-weekish one, the 20-weekish one around morphology scan, and then they're ours, GPs, until last month of pregnancy. In that time, obviously, if there's any issues, you'll refer to the appropriate clinics and get advice as need be. But otherwise, all those visits are now GP visits in between week 20 and week 36. The protocols for that are in the summary, which is at reception you would have picked up. It's emailed to you and it should be getting circulated. It obviously has the new layout of the visits on it. It also has a few of the new highlighted sections, so making sure you order the correct bloods, such as if you find that rhesus negative, you have to order a new anti-D test, essentially, which someone else will talk about. There's also, it's got on it the new vaccine, so obviously RSV vaccine is there as well, and it tells you when to provide the referrals and make sure everything's up to date. And then all the usual phone numbers are in the bottom section, same as the last protocol, so you should have all the contact information there for those as well. I'm not gonna, it's too tiny. Now, there are some new people working here, they're now heads of departments. So Wendy Hawke, as we said before, is the new director of obstetrics. Sarah Uwe, so she used to be a registrar here. She's now one of our obstetric consultants. So she'll be also one of the new shared care doctors. I don't know all the others, I apologise. But Danny at the bottom, she's great. And she's the one who's going to be answering like the GP liaison midwife phone number questions, essentially, if we have questions. I will learn whoever else is. I think Dr. Jane was one of our renal specialists that she presented at the last update. And she was a very good talker, I remember, so she knows things. So there's also a new requirement for joining us. So those of us who are grandfathered in, we did not have any necessary training we had to do, but now we ask the new GPs joining to do the RACGP's online first trimester screening module because it's super confusing, and I have registrars still calling me going, what's the difference between a first trimester and an NT versus an NIPT, and how do I order it? And I do not blame them because it is confusing, but that's why we have the online module now. So now when you are a shared care GP, you know how to do that. The rest of us who are grandfathered in, we're encouraged to do it. So please do it. There are more e-referral pathways, breast clinic now, which is great because I don't know about you guys, but I used to fax it and then not hear anything for about 4 weeks. And the patient obviously tries to chase a number that is hard to call. Now they're online e-referral, so you'll get a notification, which is very exciting. Physio as well, as you know, a lot of them get free physio when they're pregnant. So you may as well refer them into that clinic. And the other clinics are more like growth and development, for example, usually the hospitals organise that one, but just so you know, there are some new clinics there. Newborn follow-up, again, is for itty-bitty little babies. We've had NICU babies, essentially, who need follow-up. Again, we don't refer into that. The hospital organises that one, but just so you know, they're online now. There is a new MAPS brochure trying to explain the difference, obviously, between MAPS and all the other models of care, which is always nice to try and explain to patients. So if they have a little printout, I think that's quite helpful. So I'm hoping you guys receive that at the front. If not, this will be emailed around. Now, there is new hubs. So I drove down Arden Street the other day and I saw one, and it's the new midwife clinics that they're created, which is great. So it's like, you know how they used to send midwives to your houses in the first few days afterwards? There's now a place they can go. So similar to like an ECC, but it's the midwife. So there'll be more information about that later. Such as now. The lovely photo of one of them. As I said, so the Bondi Clinic is actually where the ECC is in North Bondi, because I took my baby there. So it's a corner of Waiora. So it's the same place, but now the midwives are there, not just early childcare nurses, essentially. Change of topic dramatically. Clinical placement. So this is when, as a GP, you just want to learn more because you're not great at something, or you just want to learn how this hospital works. There are obstetric clinical placements, which some of you may have done when you first started. And this is when you shadow an obstetrician, go around the wards, meet some ladies who let you examine them. And these are the dates for the upcoming ones if you would like to do them. They're very, very, very useful. And you can ask a million questions because you have an obstetrician, in front of you, essentially, that whole time. Then there's menopause hub clinics. So this is new and very exciting. And I'm doing one this Wednesday because I also want to know how to manage incredibly complex menopause patients, or what to do beyond a Slinda script and here's some Estrogel Pro. I want to learn that. So I'm going to go and do a menopause hub placement. So I do encourage everyone to do it if you get a chance. Well, the only time we get to do it is when the med students don't get to do it because they're on holiday. So this is our only, that's why there's not that many dates. So I highly encourage everyone to try and do it if you see people, especially 40, 50-year-old patients. Because I think it's going to be very helpful, essentially. There's morning sessions, afternoon sessions on different days, and there's different versions of the sessions, as you can see at the bottom. Email address, phone number. I can see some of you taking photos. If not, obviously, it'll be in the emails that come around after. These updates I'm not going to really go through, but there are new essentially protocol guidelines for how to use the oral misoprostol. You know, if they have recurrent miscarriage, more than 2 or 3 in the past, then they get to have misoprostol. I assume it's for that. No, this is the one for induction of labour at full-term gestation. Either way, we don't do this. The guidelines are on the system now, same as Syntocin. And birth to chest C-section, has anyone seen one? I saw one 2 weeks ago. So C-section, they come out and then immediately to the mum's chest, as opposed to going off and being weighed and paediatrician review, they go straight to chest and then we cut a cord. So it's a new way of essentially quicker going to the chest. So that's new and exciting, and there's a PDF about it. But just so you know, that now exists in case your women ask about it. There's that, and there's the maternal assisted C-section. Some of them do as well. It's a fun new world. Okay, GDM guidelines, new flow sheet. I'm not going to go through it. You've been through it before. As you guys know, there's that early HbA1c test you do at the beginning, not just the OGTT. But that's in the guidelines that someone else will talk about, and we talked about last time, and it will be in your book. Education classes All of this is on the Royal Women's website, and the women go to the website and book their classes. You don't have to know too much about them, but just tell them to go to the website, essentially. Obviously, CPR first aid, we encourage everyone to do that one. Tours are always available. Some parenting classes, that's always nice and helpful, because that's always, I find, the trickier part. People just focus on the birth. But I think it's good to know what to do in the first few weeks at least. So there's a whole bunch of clinics there. As you can see, Calm Birth is at the bottom. It's a bit expensive, but a lot of people find that quite helpful as well. Embody is the new physio one, the online physio one. So you can refer them, well, they can refer themselves into that one. So for before or after birth. And obviously, if you have gestational diabetes, there's physio-led exercise classes at set times, and it's free, which is quite good. Virtual maternity ward. So this is new. This has only been, I think, since November. And this is someone who could be in hospital, but probably better if we can send them home. So if they have, for example, like a stable preeclampsia, people will send them home and then they just do their reviews from home. As you can see, daily reviews, daily monitoring, and then the midwives come to visit them at home, and they can do the meds from home as opposed to being inpatient or even outpatient visits. They can stay at home, which I think is obviously nice for everyone. Termination of pregnancy clinic we're mentioning because whilst this was happening, I don't think most people knew about the fact that the Royal Women's does do terminations of pregnancy. However, it's only for certain criteria. So a lot of people will be privately doing their terminations if they don't fit this sort of criteria. So obviously they have to be in the catchment area, but they have to be medically complex or have social issues or disadvantaged, or very young, or big financial barriers. Or obviously if there's a fetal anomaly, that regardless, I think was going to be covered. But just so you know, that does exist here and you can refer for that. And there's a coordinator mobile number at the bottom there. So you can contact them if you need to. Otherwise, you can send a referral in and that way it's Medicare covered termination of pregnancy. Plan, I'm hoping you guys already know about this one. So this is the optimization of your lifestyle and nutrition while pregnant, ideally before. So there is a QR code, which is I find the easiest way to just show a patient. Otherwise, it's obviously on the Royal Women's website as well. And it just helps them, similar to the Get Healthy New South Wales in pregnancy. It's just optimizing your health, and the microphone just changed slightly. That's it. Lots of new things. Does anyone have questions? Yes, someone's coming up with a microphone.
And I give you the microphone first, so then you can speak into it and the online participants can hear as well.
Sorry, can I just ask that first slide about the electronic referral? How's that? It's like there was an email address, but is that what you mean by electronic or?
So you're on HealthLink?
Yeah.
Referral, you can now, it's not just antenatal clinic and gynecology and stuff, you can now also do those new clinics. So you can now refer to the breast clinic for their breast screen, not breast screen, but if there's a breast disorder, you can do the e-referral to the breast clinic.
Okay, so there's more options now in the HealthLink.
Standard.
Yeah, okay, thank you.
Anyone else? Anyone online? Great.
Thank you all so much. I will leave this and not touch the computer.
Thank you, Ezra. There's always so many new things happening all the time. Oh, did you want to change the? Whilst we're getting ready, we're ready already. The next talk is on genetics in pregnancy, and this will be presented by Dr. Alan Ma and Ron Fleischer. This is, okay, there we go. Dr. Alan Ma, just to introduce them, he is a clinical geneticist at Sydney Children's Hospital, Westmead, and he's an academic with the University of Sydney dedicated to making genomic medicine more accessible and equitable to all families. He currently leads a genomics research program, PRECISE, and that's funded by the Medical Research Future Fund, and this seeks to implement genomics into primary care. And he's co-designed with GPs an educational portal with resources for GPs, and this is at Medcast podcast.com.au/genomics. He also conducts research in rare disease gene discovery and implementation science with clinicians and consumers. His work bridges clinical care, research, education, policy, with the goal of improving diagnostic outcomes, empowering clinicians, supporting families navigating complex genetic conditions. And Ron Fleischer, he is the Senior Genetic Counsellor at the Royal Hospital for Women. He has a particular interest in prenatal genetic counselling, including carrier screening and NIPT. He has been involved with the Sydney Jewish Community Carrier Screening Program for many years, and he was also involved in the setup of the first public NIPT clinic in New South Wales. Please welcome Alan and Ron.
Hi, good afternoon. We're even a few minutes early. I'm going to fill all that time because I could just talk about prenatal genetics all day if you give me the opportunity. So my name is Ron Fleischer and Dr. Alan Ma. Awesome. All right. We're doing a bit of a double act today, which we haven't rehearsed, but I'm sure it'll be perfect. So first up, what is available in terms of prenatal genetic testing or genetic testing in pregnancy? We're going to talk about two main tests: reproductive genetic carrier screening and non-invasive prenatal testing. So these are different tests and they test for different things, and we're going to run through a few case examples. So unfortunately, I can't see the screen and talk into the microphone, which is a bit annoying. Do you want it bigger? Yeah, I'm going to work on that. Genetic carrier screening ideally is done in the preconception setting, but often I'm sure people come to you early in pregnancy. Yeah, can I have it just full screen on there? Okay. Yeah, no, that's okay. I can do it in my sleep. Preconception genetic carrier screening for certain monogenic conditions, ideally pre-pregnancy, so then people can clarify their carrier status and they can make their decisions about future family planning. But I'm sure people are turning up early in pregnancy, and the guidelines still say that you should offer this test during the first trimester. Where that test is looking for monogenic conditions, there's the standard Medicare panel and then there's expanded panels. It's all very confusing, but hopefully we'll talk you through it today. Non-invasive prenatal testing, or NIPT, is screening for certain chromosome conditions. It can be done as early as 10 weeks. I'm not, like, everyone thinks NIPT is just the greatest test ever. I'm not one of those people. And I don't know that there's such an advantage of doing it so early at 10 weeks, because you get your results back at 10 weeks and 4 days. If you get a high risk result, there's actually nothing you can do. The earliest diagnostic test you can do is a CBS at around 11 or 12 weeks. So, I think there's patient pressure to do NIPT early and get their gender reveal sorted and all of that. But actually, from a clinical point of view, I don't really dive into NIPT as a first-line test. I kind of like it as a contingent screen following first trimester screening if it's indicated. So NIPT is looking at fetal, but it's really placental DNA in maternal circulation. And there are fact sheets and some other resources that Alan will point you to a little bit later. So some things, this is all very nuanced. It's all very, very complicated. Both carrier screening and NIPT are not looking for everything that can possibly happen during a pregnancy. Obviously, for any couple who are having a baby, there's a background risk. There are some things we can screen for and some things that we can't screen for. So that's part of the sort of pre-test counselling, is that both carrier screening and NIPT are looking for a subset of genetic conditions. So our first case relates to a 32-year-old lady who presents preconception because, of course, she's read on her socials that there's a test you can do to make sure the baby's going to be healthy, and she wants that test. So what do you do? It's great that she's preconception because you've got time to talk her through the different options. And essentially, if we're looking at all the options, there are 3 options. There's the Medicare-funded 3-gene screen, there's expanded carrier screening, and then there is the option of no testing. So I kind of think of this as like being upsold to a bigger test. I guess I guess that other one is like the Ozempic option of no hamburger. So like a hamburger's great. The 3-gene screen is fine. It'll do exactly what it says on the box. It will screen the woman for the 3 most common monogenic conditions that we see in our community: cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. The way Medicare have decided to fund this is that the female gets a free test, and then if she's a carrier for a recessive condition, her partner gets a Medicare-funded test as well. So I suppose that leaves you guys, having to find partners who might not be part of your practice. So I'm sure there's lots of complexity at your end. Not my fault. That's the way Medicare decided to roll this out. But they can pretty much go to any pathology provider and get a Medicare-covered 3-gene screen for those 3 genetic conditions to find out their carrier status. CF and SMA are recessive conditions, so only relevant if the partner is also a carrier. Fragile X is X-linked, so female carriers are at risk of having affected males or females, but males tend to be more severely affected. The upsell is, well, if you're screening for 3 conditions, why would you not screen for 100 or 300 or 500 or 1,000? And I think that makes sense as well. Medicare did not agree, so they are not covering the cost of that test. So that's out of pocket, but there are at least half a dozen pathology providers that will offer an expanded carrier screening test. They all differ slightly. They'll all tell you that their test is the best one. They're all fine. One of the frustrating things is that you only get 1 bite of your Medicare cherry. So if you use your Medicare rebate on the 3-gene screen and then think, oh, actually, why did I only screen for 3? I wanted to screen for everything. You then end up paying full price for the expanded test, which is really about $1,000 per couple. So you can make it sort of $600 per couple if you do it ahead and apply your Medicare rebate. So just one of the nuances about expanded versus 3-gene screen. So just a slide that I pulled from the Medicare data. So the Medicare rebate for the 3-gene screen came in at the end of 2023. So there's no data before then. And you can sort of see that it's just been tracking along. And I think I worked out that they do about 3,000 tests in New South Wales every month, which sounds like a lot. And I think they would identify about 150 carriers and about a dozen high-risk couples. And so the red line there is the males that is trailing behind, not only because males are hopeless, but because the male only gets the Medicare-funded test in response to the female being a carrier. Okay, so first decision when you've got the patient in front of you is to make a decision, a shared decision about whether to do the 3-gene screen or whether to do expanded testing. And the factors would be cost. I think people are quite price sensitive. So you can offer a free test or a test that's going to cost them more than $500. That might already help them make a decision. If price is not an issue for them, then it's the nuances of the test and the idea that the expanded carrier screening covers much more, that there might be particular circumstances based on ethnicity or consanguinity that might prompt you to think about doing an expanded test rather than the fairly focused 3-gene screen. I'm glad I'm not a GP. I don't know what I would do because the more you test for, the more complicated things get, the more time it takes. And whilst the cost of the test has been funded as a pathology test, the cost of actually rolling out the test hasn't been, and there just aren't a lot of counselling services around this. So if you do expanded carrier screening, you are going to find more stuff and you're going to need to spend more time talking to patients. So how to offer carrier screening in 4 sentences. This is 2, so you might get away with only 2 sentences. So you might say something along the lines of, there are some extra testing available just to check that you are not unknowingly at risk of having a baby affected by certain serious genetic conditions. Is that something you're interested in? If they say no, you're done. If they say yes, the next 2 sentences would be something along the lines of, well, there's a basic test that's covered by Medicare that covers 3 genetic conditions, but you can also access testing for a much broader range of testing, but there's an out-of-pocket test which will be more than $500. So that is the kind of conversation that I would be having with a patient like our case example. to just get a sense of what she wants to do and how concerned she is, and whether a price point is a issue for her as well. So a few more bits of information come to light. She is quite concerned. She also discloses that there's some consanguinity in the family, in that she and her partner are first cousins, which we see from time to time, and obviously increases your risk of recessive conditions because of shared ancestry. So there's no family history, but for most recessive conditions, there is no family history. It occurs out of the blue, and both parents were unknowingly carriers for the same genetic condition. So what's next? Okay, so you offer carrier screening. They might say no, which is great. And then I would just encourage you to document it. And then you've just saved yourself, a few more minutes of conversation. But I would just document it because it is in the guidelines now to say, you should offer this to everyone in the preconception and first trimester. If they do want to do carrier screening, the decision tree takes you down into, well, are we going to do 3-gene screening and are we going to do expanded screening? Then if we're going to do expanded screening, you can screen both people together and get back a combined result, or you can screen the woman first and then reflex to testing the partner if needed. So there's just a bit more complexity if you go down the expanded screening pathway. Deciding on which lab to use, there's at least half a dozen labs in Australia that offer this. When I talk to patients, I just say, look, it's a bit like Telstra and Optus. They're fine. They both do a perfectly good job. There are little differences, but essentially whatever you're doing is better than doing nothing. So the decision for you guys will probably be determined by, convenience and relationships that you've got with pathology providers. If they gave you a free pen, yeah, probably use them. They're all fine. And once you've screened for the first, 200 conditions, 300 conditions, I don't think I wouldn't lose any sleep about doing 500 conditions or 600. It's just statistics. So our patient goes off and has expanded carrier screening and comes back as a high-risk couple. Perhaps because they were consanguineous, it was more likely that they were going to be carriers for a rare condition. This is a super rare condition that I haven't heard of, but Alan probably has. And when a couple are carriers for the same recessive genetic condition, they're at 1 in 4 or 25% risk of having an affected child. And so that would hopefully prompt you to make an e-referral, which you can now do. And that will land in my inbox, and we will contact them promptly and offer them an appointment and talk through all their options. So I guess my messaging at this point is to keep calm and refer. Yes, it's a high-risk result, but that's fine. The best thing about her situation is that it's preconception and all their reproductive options are available to them, and they've got time to think about how they want to tackle their future family planning. So if you are referring to the Royal Hospital for Women, you can make an e-referral. I don't know what the system is at your end, but it just lands in my inbox. It's been pretty amazing. And then we'll see them and we'll talk them through the condition, the spectrum or the severity of the condition and their options. Essentially, their options being no testing. They'll just roll the dice because that's how they are. They might decide to do a prenatal test, which would be either a CVS or an amnio. Or they might go down the pathway of IVF and pre-implantation genetic testing. So the whole issue with carrier screening is that we can't offer prenatal testing until we know what we're looking for. So people have got to have carrier testing up front, and then if they are identified as a high-risk couple, they've got options. If you receive a low-risk result or a low-chance result for your patient, please don't refer them. We don't have time. We cannot see them all. And also, if you've screened one partner and she's a carrier and then you've screened him and he's not a carrier, you've just got to follow the advices on the report. We can't see those people either. There's just not enough resources in the public system. There are some private services around. If people wanted to talk more about it and what it means for other family members and, should my sister be tested? A lot of stuff comes out of this kind of testing. So there are private clinical genetics and genetic counselling services available that you might want to point them in the right direction. Still me? No, it's you. Okay.
All right. I'm going to go through case 2. And we're going to have time for questions at the end, I think quite a bit of time. So if you have any questions, please hold on to them. So I'm going to go through Sarah, the case of Sarah, who's 36 and saw you for a preconception consultation where you discussed reproductive carrier screening, and she elected to just do the Medicare-funded 3-gene screen. And lo and behold, she's come back as a pre-mutation for Fragile X syndrome with 29 repeats and 75 repeats and 2 AGG interruptions detected. This is a bit of a mock-up of the kind of report you might get, and I'll go through it with you. Just to kind of wake us all up and have us all thinking a little bit about this, what do you guys think? When should you refer a person for genetic counselling regarding Fragile X? With A, any repeat size, B, expanded repeat size only, over 200, C, pre-mutation repeat size and expanded repeat size, or D, no one. This was meant to be interactive, but I'm going to go old-fashioned with hands. Let's see, how many people think A, any repeat size? So this is for genetics referral. B, expanded only, so over 200. C, pre-mutation repeat size and expanded repeat size, or D, no one. I'm glad no one put their hand up. So the actual answer is C, and the reason is that the pre-mutation repeat size has implications. Now, this is one of the nuances of preconception carrier screening, that the 3 conditions, SMA, Fragile X, and cystic fibrosis, while they were picked by the, the wise MBS gods that, these were the 3 that we should check, they're actually really complicated conditions, and they each have a lot of nuance in the genetics and the inheritance and in the interpretation. And this is the one of the ones that is actually fairly common. I probably see this, at least once a month. We get a referral from a GP for this. So what am I talking about? So Fragile X syndrome. So in the past, we thought Fragile X syndrome causes, number 1 cause of autism in boys. They have this massive expansion on the X chromosome and it interrupts the gene, and they get severe autism. They're often non-verbal and they have a bit of a physical look about them. What happens in that gene is that it's kind of like, when you type on the computer and you sometimes accidentally leave your finger on the C button or the space bar, it's like that for the gene. CGG just gets repeated throughout that gene way too many times, and it interrupts the whole gene. Depending on the number of CGG repeats, you can either be an intermediate allele carrier, a pre-mutation carrier, or an expanded allele carrier. And so those are the numbers that you roughly get, 45 to 55, 55 to 200, and over 200. And the AGG repeats, which is even more complicated and mind-boggling, is that if you get these accidental AGGs instead of a CGG, it actually stabilizes the gene and it makes it less likely to expand in the next generation. And that's the main worry for someone who's a pre-mutation carrier. For them, there are health implications, but for the next generation, that Fragile X, that FMR gene could expand into the full mutation range, and they could end up having an affected son with severe autism and intellectual disability. So that whole pre-mutation to expanded range is an indication for referral. Now, this is really complicated, and I have to look it up every time. So I would not expect a GP to know exactly what that all means and all the ins and outs of this. And I guess just like what Ron said, don't panic. You can always ask for help. If you call your local genetic service, they will talk you through this, and they will talk the family through this, because it is really complicated. What's happened here is that the lab, and some labs do different things. Actually, every lab does a different thing. The lab's already done the AGG interrupt repeats for you. What that AGG does is it gives you a statistical probability on how likely that pre-mutation is to go higher into the mutation range. And it could be as low as 0%, or it could be as high as 50%. And so that actually then gives you something to say to the family about, okay, you're a pre-mutation carrier, but your chance of this expanding is next to nothing, don't worry, or it's actually quite high. We need a prenatal test for this. Not every lab does this though. And so most patients that get referred to genetics, we end up doing the AGG repeats because it's not automatically done, because it costs the lab money and they want to do the minimum. So it costs about $300 to $500, and we try to do it as quickly as possible. The other tricky thing is that, especially for the woman, there is actually implications for her health from being a pre-mutation carrier. So there's Fragile X associated primary ovarian failure, which obviously would be a concern, especially if they're planning a pregnancy. There's also Fragile X-associated tremor ataxia syndrome, which usually affects males and usually in later age. And then there's this emerging phenotype that we're seeing where we think that just being a pre-mutation carrier actually has a bit of a neuropsychiatric implication for you. And it kind of makes sense. Like, why should boys just have severe autism when they're over 200? You know, what's magical about 200? You know, in that reduced range, it probably does have some effect on your brain. And so we're starting to see this emerging phenotype come out. This is a fact sheet from Fragile X Association Australia, and I won't read through all of it, but it just gives you some figures on the percentage likelihood of developing the FXTAS, the ataxia syndrome, the ovarian failure. And, you know, these are kind of rough figures, actually. They're not 100% accurate. And we wouldn't really expect the GP to talk through this with your patient, actually. It's worth knowing about it and having an idea about it, but this is stuff that the genetics service would talk through with the family. And actually, Fragile X Association is also happy to get calls from families, and they field calls from all over Australia about this and talk to families about it. That's another link to the Fragile X Association. So they're a very good support group for these families. Oh, and we're back to Ron.
Okay. So what have we got? Okay, so we're going to shift gears. We've done carrier screening, but maybe should we take a minute for questions on carrier screening before we move on to MIPT? Yes. I can repeat the question. Are there any advantages? Yeah. Okay. So the question was, if in a preconception setting, where you're doing expanded carrier screening, should you do things sequentially or should you do things concurrently? So should you test both partners together or should you test the female first and then only test the male if needed? So this will be just completely dependent on which pathology provider you use. So some pathology providers do couple screening and offer a couples result, and that's the only option that you have. About 2/3 of people that you screen for expanded carrier screening come back as a carrier for something. So I think by the time you've tested her, you may as well do him as well. So I think we are shifting towards couple screening because then many labs don't give an individual result. They'll just say you're a low risk couple. And even if one of them is a carrier for conditions A, B, and C, and he's a carrier for X, Y, and Z, it doesn't matter if you're not a carrier for something in common. And so that just simplifies the result delivery. And as long as people have babies with who they tell us they're going to have babies with, which is no guarantee, but out of our hands, you're covered, but you don't know your individual carrier status. So there are pros and cons. It's going to be dictated by your favourite pathology provider.
Yeah, I was going to say that exact issue. Repartnering is pretty common, and having a low-risk combined carrier testing might falsely reassure someone, oh, it was negative last time, it'll be fine, but you'd need to repeat it with the new partner as well. And I think that's one of the worries we have about the triple screen. Often, if couples haven't had much counselling, oh, they've just had the 3-gene screen, they think they're fine. That's a lot of false reassurance that's probably out there that couples think, I'm fine, and then they have a child with one of those hundreds of rare conditions. So I guess it's the risk of false reassurance versus, full reassurance.
Is this working? Yes, it's working. Okay. Eugene Labs versus the Australian-based labs, because Eugene Labs, people can self-refer. Do you guys have a preference? Which one's which?
They've given me a pen as well. They have genetic counsellors on staff, and I believe they do a good job. And it makes it easy for you guys. So, yep, Eugene Labs would be fine.
Yeah, I mean, we probably have a slight conflict because we know the people who run these labs, but we don't, work for them or anything. That Eugene is a good lab and run by good people. Often really helpful for rural patients that I see, or people who are hard to get in because they get a saliva kit sent straight to their house. They just send it back to the lab. Everything's done on their phone or on an app direct with the lab, including good genetic counselling. So yeah, I think they're fine. They're good.
Oh, hello. Yeah, okay. Online question. Can you talk about insurance implications, if any, particularly for the expanded screening, and how would you counsel the patients in regards to that?
Well, I would say wait till October because the legislation is going to change in October and there won't be genetic discrimination. So we're only worrying about this for a little bit longer. There is a small chance when you do expanded carrier screening and get your individual result back that you'll get back some information that has personal health implication for you. So the gene for hypercholesterolemia is on there, for example, because homozygous FH is a really significant and difficult to manage problem, but heterozygous FH, is going to cause likely that the parent's going to have high cholesterol, and that sends them down a whole management pathway as well. There's a small chance of finding a cardiac or a cancer gene risk. It's not the purpose of the test. These are incidental findings, and they're relatively uncommon. And I think probably the benefit of doing the test and reducing your risk of having a child with special needs is offset by the probably 1% chance of incidental finding.
Yeah, I think I think insurance comes up a lot, and health insurance and income protection. And up until very recently, we've had to say, seek some advice, talk to your financial advisor. But there is legislation to ban genetic discrimination now. So it's being passed, and short of a change of government or something awful happening, it'll be passed this year. So I wouldn't worry so much about that.
To do it that way.
Yeah, that's
each together.
Yeah, so basically the expanded carrier screening, let's say it's $1,000. If you haven't already used your 3-gene screen Medicare, they can apply that to the expanded carrier screen and bring the cost down. Yeah. So yes. Yep. So I meet a lot of unlucky people. We have a perinatal loss clinic. So I meet a lot of people coming through who have had a fetal death or a stillbirth or a baby with multiple anomalies. And often they've had the 3-gene screen, then they've had this unrelated experience, and suddenly they're aware of all the terrible things that can go wrong. And they say, look, we want to tick all the boxes now. And then unfortunately, they're up for the full cost of the test. Yeah. Yeah. So the question was whether the labs provide any support or genetic counselling. I think the support to you in terms of online information sheets is there. I think the reports are pretty good. A couple of the providers have got genetic counsellors and will include that, but only under very certain, like they've both got to be carriers. I think I've had mixed experience from patients about the genetic counselling provided by the labs, to be honest.
Yeah. I think so. I think the best thing is still to call your local service, even just for a phone call, to ask for some advice, because the labs do offer it, but it's not always that helpful.
And just in terms of the local service here, there's the genetic service at Sydney Children's Hospital, but all of this work should come to the Royal, which will come to me and my colleague Beth in maternal fetal medicine. So Sydney Children's Hospital for paediatric and even adult genetics, and the Royal for prenatal stuff and family planning. Yep.
What's your opinion about that? They seem to be telling us that they're also offering the genetic counselling as part of the package.
Yep, absolutely. So the question was about private providers. So Ultrasound Care and Sydney Ultrasound for Women have genetic counsellors on staff. They'll do a great job. Great option. It's not the cheapest place to get a scan done, but that's the trade-off. Yep. You can book in and have carrier screening, have a conversation about carrier screening with them, and they'll facilitate it all. Yeah, it's either you or someone else. And yep. I think, yep. Yeah, so there's a few. Is there a difference between different labs and within Australia and Australia versus overseas? So if you use an overseas lab, you can't apply the Medicare rebate. So some of the overseas labs are a bit more expensive than what you can access here. I would say that if you're talking about expanded carrier screening, they probably all have the same core, I'm going to say 200 genes. And then after that, it's just a mix of their favourite genes. And I don't think it matters too much.
Yeah. It's pretty hard to tell the difference. And some labs, it's actually really hard to get a list of those genes, actually. So, and I wouldn't expect you to trawl through that list of genes. So these are often selected on severity. So it's severity of childhood onset conditions, not really on ethnicity. And it's tricky because our population is, ethnically very mixed and increasingly so. So it probably is okay regardless of panel, as long as if it's a couple of hundred genes, it'll cover the commonest couple of hundred severe childhood onset conditions.
I think better and probably cheaper for the patient. Yeah. Your question did just remind me to, if someone has a specific family history though, if they come in and say, oh, I have a niece with phenylketonuria with PKU, you or someone needs to check that PKU is on the gene list of the test that you're doing, or that would be a valid referral to us. If there's a family history, we're happy to see and guide them. Screening we can't do. We leave that to you. Question down up the back. The question for those online was about Klinefelters, and it's like you've looked ahead to our slides, so I'm going to hold that question for a moment. Gosh, spoiler. But no, there's no insurance implications for testing during pregnancy.
No, it shouldn't affect their insurance. In fact, it means that they can get NDIS and other things later on as well. So I think it would be important to get that diagnosis.
John on the right here, or no, never mind. Questions? Right, move on then. Yeah.
Okay. So in summary, reproductive carrier screening, ideal to do preconception. So I guess if people are coming in to say that they're going off the pill and thinking about family planning, that is an ideal time. And yeah, I guess a fairly complex conversation about whether to have the standard or the Medicare covered test or to have expanded carrier screening. And there are pros and cons that you need to work through with them. So the case study that we've got here relates to a lady who's come in and she's 9 weeks pregnant. And again, she says, I know there's a test you can do to guarantee me of having a healthy child. And you'll say, well, there isn't. There's always a risk in pregnancy, but there are a number of options that you can do in terms of screening for common chromosome conditions. So my Venn diagram didn't quite work here, but I'm sure you can imagine that line that should be there. I really think of NIPT and first trimester screening as complementary tests. In the middle there are the things that they both screen for. So they both screen very effectively for Down syndrome, trisomy 13, trisomy 18, and Turner syndrome, because on ultrasound, those babies will almost always declare themselves either on the 12-week scan or at a 20-week scan, and NIPT is highly sensitive for those problems as well. As I said, I already declared myself as being a fan of contingent screening. I think if there's no reason to spend $500 on NIPT, I don't know that it has to be a first-line test, but they're the options that are available to people, NIPT and or first trimester screening. So first trimester screening relates to nuchal and first trimester blood, so beta HCG and PAP-A, which improve the sensitivity of the test and can also give you information about preeclampsia. There are lots of things that first trimester screening will pick up that NIPT won't, and things that NIPT might pick up that first trimester screening won't. So you've got that overlap, and then they've each got other I guess, strengths and weaknesses. So running through the options, again, this is probably something that you'll decide on based on the pathology provider that you're using, but the standard NIPT test checks for Down syndrome, trisomy 13 and 18, and then there's the option to find out the biological sex of the baby, so they look at X and Y chromosomes. And then sometimes there's a tick box about sex chromosome variations as well. The question down the back was specific about Klinefelter syndrome. So we see Klinefelter syndrome, which is XXY, boys with XXY. We see girls with XXX, and we see boys with XYY, and all sorts of other sort of permutations and combinations. So the standard NIPT test looks for what we would consider common chromosome conditions. The next two options is expanded NIPT, looking at microdeletions and microduplications. And then there's another option of genome-wide NIPT, which looks for copy number variants. So I really do feel for you trying to be across this really complex and nuanced information. I think it's a question of understanding what's available to you through your preferred pathology provider, and then talking to your GP about, you know, what's available and what your preferred practice is. And I'll often say to people, look, you might just want to keep things really simple and look for the most common chromosome conditions like Down syndrome, trisomy 13 and 18, or you might want to be all in, but you have to then accept that there's a higher risk of false positive results, and it might send you down a rabbit hole of doing further testing. Further testing is invasive testing and carries a risk of miscarriage. So just sort of planting that seed that the gender reveal should not be the focus of their decision about NIPT. So how to decide which test? So interestingly, I learnt this, I don't think I knew this until I did this presentation. The current guidelines say that there isn't sufficient evidence to offer genome-wide or expanded panel testing on NIPT. So the current guidelines would support keeping things fairly contained and just looking for Down syndrome, trisomy 13 and trisomy 18. So I think that's a reasonable position. Many patients will say, oh, I want to test for everything. So that's fine, as long as they're going into it knowing that there is an increased chance of false positives and an increased chance that they'll end up needing an amnio to clarify what's going on. Oh, please, this happened just the other day. Please make sure people have had a scan with their NIPT. This is a 20-week baby with anencephaly, and they hadn't had a scan because they did NIPT at 11 weeks. They got a low-risk result, and then her first scan was at 20 weeks. So it's just so sad and unnecessary and not great medicine. So please do a viability or a dating scan with NIPT. And I guess that's the other reason I'm not here to plug Sydney Ultrasound for Women or ultrasound care, but they do a good service in that they always do a scan, even a quick 5-minute scan in conjunction with the NIPT, so people know that they're spending $500 on a viable pregnancy, not a baby that miscarried 10 days ago and they hadn't yet, clinically presented. Okay, so our patient goes to have NIPT at 11 weeks, and she gets a low-risk result for trisomy 13, 18 and 21. Great news, but as manifested by someone down the back, she comes back with an increased risk result for Klinefelter syndrome XXY. So obviously it's stressful for you, it's stressful for her, but she's very anxious and she wants to discuss what the next steps are. So Klinefelter syndrome, XXX, XYY, these are sex chromosome variations that were traditionally or previously completely underdiagnosed because people didn't always come to medical attention, and they certainly didn't come to medical attention at 11 weeks gestation. So this has been an unexpected, I guess, result of the uptake and success of NIPT, in that we're now diagnosing a lot of people, or a lot of babies, early in pregnancy with sex chromosome variations, for which the phenotype is very varied and relatively mild. the boys with Klinefelters will be infertile. There might be some key learning problems, but these boys are in mainstream schools. They're going to need some help. They're going to need to see an endocrinologist along the way and going into puberty and things like that. But if you're doing a test for Down syndrome and trisomy 13 and 18, I guess on a spectrum, trisomy 13 and 18 are usually considered lethal conditions. Down syndrome somewhere in the middle, and sex chromosome variations are very mild. And I always tell people that they're, if you stand in Pitt Street Mall, 1 in 1,000 people who walk past are going to have XXX or XYY, and they're living their life and not aware of that. So complex information for people to receive during pregnancy, and then making decisions about invasive testing. Not that the risk of miscarriage from amnio or CVS is particularly high, but you're then weighing up a decision about risking a pregnancy to find out information that you weren't really seeking anyway. But no one likes to, sit with uncertainty. So it makes for an interesting job for me. So how to manage increased results. Once again, keep calm, keep the patient calm, refer to maternal fetal medicine. They'll be seen very promptly for genetic counselling and diagnostic testing. We sometimes try and offer a bit of a one-stop shop. So they'll come in, we'll have a preliminary chat to them, we'll do a scan, and the scan is incredibly useful. So if someone's come in with an increased risk result for Down syndrome, on the 12-week scan, we're either going to see an increased nuchal, a hint of a cardiac defect. If we don't, then we're thinking, well, could this be a false positive? If we do, it's kind of supportive of what we've seen on NIPT. So we generally have a chat to people, get them in for a scan, and then see whether CVS or amnio is the next step if they're open to invasive testing. There are pros and cons for CVS and amnio. CVS is good because it's early, and if couples are open to stopping a pregnancy, they sometimes want to keep things happening sooner rather than later. In the fine print, though, CVS is a biopsy of the placenta, so it's not quite as accurate as an amnio because you're getting placental cells rather than fetal cells. So there's a lot of complexity to these results, and it's actually a pleasure to sit down with people and just work our way through the decision making and helping understand the information and where they're coming from, and making a shared decision about how to move forward. Many people will do invasive testing, so they'll have a CVS or amnio, which will either confirm the results or prove that it's a false positive. If the results are confirmed, couples have got an option to stop a pregnancy if that's what they decide to do following counselling. Okay, some take-home points, which I actually can't read because they're small on my screen, but they're on the big screen, so you can read them. And then I think the last word is back to Alan.
Thanks. I might just quickly read through these. So the take-home points are to offer reproductive carrier screening to all individuals planning a pregnancy, regardless of ancestry or family history. Support informed choice for patients by discussing all options, considering their background, budget and values, and be aware that clinical considerations for Fragile X premutation carriers exist and to be referred soon. Know when and how to refer for counselling, and as well as the differences between the combined first trimester screen and NIPT, and the limitations of these screening tests and when a diagnostic test is needed. That's a lot to cover. And one thing we really realised is that, for GPs, you're increasingly in this genomics world. And the real difficulty is that most of this, it wasn't taught in medical school. It definitely wasn't taught, in the GP curriculum. And so there's this massive gap out there of what Medicare thinks you should be doing and what the colleges think you should be doing, and what actual training and support and resources and tools you have for this. So that's where I've been very lucky to lead a project called Precise, where we've actually co-designed a genomics portal with resources for GPs, but we've actually done it by co-designing it with GPs, because we didn't want to just create another thing out there with hundreds of pages that are really hard to read and really hard to use. We were really listening to what GPs wanted and the feedback on how they wanted this designed. And what they mainly told us is that they want some fast, easy, tip of your fingertips type resources that you can quickly look up with patients. They want some longer learning, e-learning modules, webinars, other types of resources. And so we've created all of this. It's free. It's at medcast.com.au/genomics. We have a table at the back out there that you can talk to us and ask questions about genetics and genomics and take some flyers with you. It's also coming live onto best practice around August. So the Medcast, which is the platform this is on, is going to be like native on best practice. So you won't have to do another login or anything else. And there's also coming an AI platform on this as well, which is really interesting on how that might work. There is a whole section on genetic testing in pregnancy and planning on that portal. So it covers what we've talked about today, but a little bit more as well. The 4 topics the GPs told us they wanted was pregnancy, testing, because it's increasingly complex. What tests can you order, can't you order, what's on Medicare, what isn't, how to refer and what should be referred to genetics or not, and also cancer, because there's a lot of cancer out there and everyone's got a family history of a cancer in somebody. And so who should be referred, who shouldn't, what should be done with these families. So that's all available now at the Precise portal. Here's just some examples of the things we've made. We've printed some of these fact sheets out and they're available at the back there. But really simple, like 2 pages on NIPT or 2 pages on carrier screening, a bit of a guide on who should be referred. One thing we're really proud of that I didn't even think about this until the GPs all mentioned it is we've got the only genetic testing available genetic testing table available for GPs. You can look up some of this information on Sonic and other companies, but you never quite know whether to trust them or if they're just trying to channel you into their, to give them money. This will tell you what tests can be ordered, what the Medicare number is, what the indication is. We made a traffic light system. So the orange tests are like things you should think about. The red ones are things you should not be doing. And often it might be even helpful to show this to your patients because they might be going, oh, I need a test for Huntington. And you can say, hey, look, it's in the red column. I shouldn't be ordering this for you. You need to see genetics. So please have a look at this. It's really, really helpful. And we're launching an AI platform with this as well. And at the moment, we're about to launch, so this has been live now for a few months, but we're about to launch an evaluation because we want to hear from GPs and what they think about this so that we can improve it and learn from this to do more in the future. We're also going to do some paid interviews with GPs to ask them what they really think about the portal. So we'd love you to log in, look at the resources there. There'll be some flyers and emails about recruitment for the research. We really want to hear from you because we really want it to be useful for you and practical and helpful for your patients as well. And I'm also going to hang around in afternoon tea with Anya from Medcast. So if you have any questions about genetics or anything about genetics, feel free to ask us and have a chat. And that's my email there as well. I'm happy to answer any questions. And I think that's the end of my plug and the end of our session. Do we have time for questions or oh, okay.
Yeah.
I'm going to try and get to everyone so we can.
You mentioned contingent testing with NIPT in combination with combined first trimester screening, I'm assuming as a follow-up after a potential higher intermediate risk result. Is that something that you would that we would order while also putting through a referral, or is that something you would use when you're then consulting with patients around NIPT results or around combined first trimester screening results?
Look, I guess if I was seeing a low risk patient in their early 30s, I would start with first trimester screening, so a nuchal and first trimester bloods. If they're not reassured by those results, then you can head down the pathway of NIPT. But there's every reason that they could and should be reassured by the first trimester screening. That's what used to happen before NIPT came along. I don't know whether it's patients who are so keen for NIPT or pathology companies, but the obstetricians love it. Yeah, there was no epidemic of Down syndrome before NIPT came along. Nuchals and first trimester screening is a perfectly fine first start. I haven't looked at what the costing is to get your nuchal done at Sydney Ultrasound for Women or not, but $500 for NIPT, I don't know, I'd buy an iPad mini.
Any other questions?
There's one over there.
what was the rate of false positives for the NIPT, just so that we've got some kind of counselling tool?
It's so hard to tease out because the website will say this is the most accurate screen for aneuploidy. It's highly accurate for Down syndrome, more than 90% accurate for Down syndrome, probably more than 95% accurate for Down syndrome. It's slightly less accurate for trisomy 13 and 18, but still pretty good. But again, most of those babies have multiple anomalies that you're going to pick up. And then if you decide to go for a genome-wide scan or look for microdeletions, the PPV, which is a stat I don't really understand, positive predictive value, is about 20%. So 1 in 5 of those results are correct, which is pretty different to 99 or to 9%. Yeah.
And the sex chromosome aneuploidy accuracy is less as well.
Yeah.
I think on one of the fact sheets that we created for Precise, we've got that data that we've tried to extract from as many pathology companies as possible, but it's pretty murky what data they put out, which makes counselling really tricky. But for the genome-wide, I think I've definitely had more cases that are false positives than real. That, you've got something on chromosome 7 and this family's now really freaking out, and you do an amnio and it's not there. So that's really the risk that we run with this, and that happens more often than an actual real aneuploidy.
Yeah. If I was delivering an increased risk result, I would definitely be saying, oh, look, this is a screening test. You come back high risk on the screen, but that does not mean that there's a problem. It just means that we should move down a pathway of looking about doing some further testing. I'd try and keep things, keep calm.
Question at the back.
Yeah, good question. So if you've done IVF, do you need to do aneuploid screening? So if you've gone to a low-cost IVF provider where they haven't done aneuploid screening, absolutely. All they've done is got you pregnant. If you've gone to a fancy IVF provider and they've done screening of the embryo before transfer, so that's called pre-implantation genetic testing, the accuracy of that is probably also more than 90%, but I would still probably do some screening.
Yeah, and I'm pretty sure those fancy most places would also do the carrier screening for you as well, because if you're going to go to all the effort of IVF and all of that, might as well just check that they're not both carriers for cystic fibrosis or whatever. So it depends on the company, but I think a lot of them will do the screening tests.
So just to jump back to carrier screening for 1 second, if everyone did expanded carrier screening, about 2% of couples would come back as high-risk patients. So I think that's a really good stat for you guys to have when you're offering carrier screening. But this test, I think of it as like taking out an insurance policy. You probably won't need it, but if you do need it, you'll be glad that you have it. About 2% of couples come back as high risk, as couple carriers, or increased risk of having an affected child on expanded carrier screening. All right. Got the last word? Cool.
I think that's probably all we've got time for.
All right.
Yep.
Thank you so much to you, Alan, and you, Ron, for talking. This was really educational. I learned a lot. So thank you so much. So we've got another talk and then we'll break for afternoon tea. So our next presenter is Dr. Madeleine Sheppard. She's talking on medical termination. Maddie has worked as a staff specialist at the Royal Hospital for Women since completing her laparoscopic fellowship in 2024. Maddie works across a range of gynaecological services at the Royal and is the clinical lead of the termination of pregnancy service that's available at the Royal. She also practices gynaecology privately at Bondi Women's Health. Please welcome Maddie.
So much. What a talk to follow. That was amazing. Thank you. So I've done a talk before that some of you would have heard before as well, that was on termination at the Royal and just sort of termination in general. I'm going to focus a little bit more on early medical termination, so a little bit more of what's done in the community and do a little bit of troubleshooting to hopefully make you all feel comfortable to do so. So I guess just a little bit of a rundown in terms of legalities. So abortion is now legal in all states and was removed from the Crimes Act in New South Wales in 2019. So a doctor can perform an abortion up until 22 weeks without needing to consult with another clinician or any other sort of further checks or balances. After 22 weeks, this is when abortion needs to occur in a hospital or a approved health facility and to be approved by a specialist medical practitioner with consultation with another specialist. Practitioners, as always, who have a conscientious objection need to provide information to the patient about onward referral. So I guess just briefly about the size of the problem, 1 to 3 in 4 women will have an abortion within their lifetime. So it's really common. About 80,000 are done per year in Australia, and about 90% of these occur at less than 14 weeks, with only about 1 to 2% being performed at greater than 20 weeks. Medical abortion in the form of MS2 step has been available since 2012. So globally speaking, in countries where both medical and surgical termination are available, there's about a 50-50 uptake between each. In Australia, the stats have been that about 30% of abortions are performed medically, so behind the rest of the world. But having said that, I think this is changing and that we'll see the numbers moving on this. This is partly through increased awareness, but also that you no longer need to be a registered provider in order to prescribe. So you used to need to do online training, but you no longer need to do this as a GP or pharmacist. There is also some possibility for nurse practitioners and midwives to be accredited as well with some additional training. So this is just a little bit of a rundown, I guess, about gestations that medical and surgical termination can be performed. And essentially, medical termination can be performed at any gestation. So before 9 weeks and 0 days, 63 days, mifepristone and misoprostol can be given as MS2 step in the community. After 64 days, so 9 and 1 onwards, this needs to be mifepristone and then a multi-dose regime of misoprostol within the hospital sector. DNC, or surgical termination, is performed usually from about 7 weeks at the earliest gestation. Now, we try not to do surgical termination prior to that because we do have an increased risk of actually missing the gestational sac. And by definition, dilatation and curettage is up until 12 weeks and 6 days. After this, we would refer to it as a dilatation and evacuation. And some centres would do that up until even 24 weeks. So I guess just a little bit of when you're counselling a patient about medical versus surgical, what are the things that you need to talk about, the pros and cons? And I guess with medical, one of the things that can be beneficial if a woman turns up very early is that medical can be used at the extremes of gestation. So with increased diagnosis of pregnancy early, this can be a real benefit for women who might just want to get this sorted as quickly as possible. It can be done via telehealth and avoids anaesthetic and surgical risks of surgical termination, and with that, also the risk of Asherman syndrome. It's low cost and can be done in the comfort of one's own home. Surgical benefits some women who may not want to follow up, which is an essential component of medical termination. And for women who are worried about having pain or bleeding to deal with at home, it can be a good option. There is a lower chance of retained products of conception, but the rates of retained products is low in both groups. Some women might also elect to have an IUD inserted at the time, so this can also be something that they might pair together. And for some women who might not want to have exposure to seeing any pregnancy tissue, again, surgical might be a good option. So MS2 step, so it can now be prescribed by GPs. And as I said, up until 9 weeks and 0 days, it's just the cost of a script and it is on an authority script. Again, yes, it can be offered by some teleabortion providers with a minimum cost of about $300. And this obviously can increase if the patient does need a scan or other tests on the side of this. It's important to think about co-prescribing. So always with an NSAID, it's probably actually the most helpful thing to take some ibuprofen about 30 minutes prior to taking the misoprostol, plus or minus something stronger like sampanidine fort. The process itself, but also the misoprostol can be a bit nausea-inducing, so having an antiemetic is also a good idea at that time. and always just thinking about what contraceptive options is this woman interested in and whether to prescribe something concurrently. There's no routine antibiotic prophylaxis required. So just a bit of a rundown on the actual medications. So mifepristone is the first medication, and this is given about 36 to 48 hours prior to the dose of misoprostol, and this is just a single 200 milligram oral tablet, and this works as a progesterone receptor antagonist. So this basically stops the pregnancy growing, or that's the aim, and starts to disrupt the attachment of the pregnancy, helps to soften and to dilate the cervix. Side effects are actually pretty uncommon with the mifepristone. It's more the misoprostol that we see women might have some side effects. So misoprostol is given buccally, so it's 4 tablets which the patient needs to put just under their cheek and holding it there for about half an hour. And this basically is a prostaglandin analogue and sort of brings on the onset of bleeding and cramps. So as I mentioned, the side effects are a little bit more common with this, so commonly things like nausea, vomiting, having some diarrhea or mild fevers. A few contraindications to be aware of, and some of them are pretty obvious, but obviously if you have any concerns about suspected ectopic, if the patient's on blood thinners, thinking about, well, what's this woman's access to emergency medical care, and then thinking about, his own IUD in situ, are you worried about an uncertain gestational age? So really important, you can give MS2 step without having a scan, but I guess through the Royal, if we are prescribing MS2 step, we do tend to do a scan. I think if you are prescribing to someone without a scan, they need to be pretty sure of their dates. Okay. You need to think about the appropriate logistics. So do they have a support person? Do they have childcare, access to ED, planned travel? It's usually about the 3-week mark that you're going to be following these patients up. So that's the time frame I'd be thinking, what's their situation over that time. There's no problem using MS2 step in women who've had a cesarean. You can use it in multiple gestations, and it's okay to use with women who have fibroids or uterine anomalies as well. In some ways, that's actually quite a good group to use this in. And you don't need to give anti-D, so no rhesus testing is required. Good opportunity to just, yeah. Oh, yes, sure. So the question was just in regards to anti-D in medical termination. So the guidelines would suggest that for surgical termination, we do need to, because there's probably a little bit more crossover of that fetal blood cell potentially to the maternal blood cell. It's still actually probably quite a low risk of maternal alloimmunization. But yeah, the evidence would be that for miscarriage, that's spontaneous, or for medical termination at these gestations, we don't need to give anti-D. It's a good time to think about opportunistic cervical screening, so you can always get the patient to do a self-collected CST and potentially STI screening if relevant as well. So if you've got the patient in front of you, thinking about screening for chlamydia and gonorrhea is recommended, and that can be just done by a self-collected swab, which there is better evidence for than a first-pass urine. But don't delay actually starting the process, so you can communicate these results to the patients once they've started. You can also, if possible, do some antenatal serology as well. In terms of hormonal contraception, it's ideal to commence it at the time. So you can actually start the day after you've given the misoprostol, and there's really no benefit until waiting for return of menses. Fertility can return as early as 2 weeks, so it's important to just counsel women about this. If it is started within 5 days of termination, then there's no additional contraceptive cover required, but at greater than 5 days, you need an additional 7 days of barrier contraception. And IUDs can be inserted from as soon as the termination is considered complete. And I'll go through how that's defined shortly, but usually I'd be thinking about that from around week 3. So I guess speaking to patients in that decision-making process is really having an idea of what to expect. So usually if we take the mifepristone tablet, and then 36 to 48 hours later, taking the misoprostol, we'd expect pain and bleeding within about 1 to 4 hours. This can be heavy, and I counsel the patient that it can be heavy for a couple of hours, so expecting some large clots, but recommending that they present to ED if they're saturating more than 2 pads per hour or passing fist-sized clots. Bleeding should then quite substantially reduce, but like most women will have about 10 to 16 days of light bleeding. It is really important to counsel women that if they don't have significant bleeding at that time, that they should be in contact with you, because you'd be thinking about whether we need to give another dose or whether there's potentially an ectopic or something else going on. Pain can be quite variable, so mild to severe, and as I said, an NSAID's probably the most helpful thing with that, but do think about some stronger analgesia as well. And once the main products are passed, women would usually just feel some mild cramps for a few days after that. Again, co-prescribing an antiemetic, we would expect pregnancy symptoms to start to resolve within about 48 hours in terms of nausea and that kind of thing, but breast symptoms may last a couple of weeks. So just a little bit of a visual representation about women's experience in terms of the heaviness of bleeding and in terms of the severity of cramps. And I think give you a moment to absorb that. But then I guess more interestingly in terms of expectations, you can see about half of women found that it was as expected, and quite a substantial 30% or more in for bleeding, pain and overall experience actually found the process better than they anticipated. So complications, and I think this is probably one of the big things in thinking about prescribing as well. What are the complications? What are the risks? What are the troubleshooting kind of things? And how do I deal with those if those do occur? And obviously the big thing that we all think about is that risk of continuing pregnancy. It's really low, so less than 1%. Incomplete abortion, so what I mean by that is some retained products of conception, is about 4%. Again, infection risk is low, so 0.2 to 1.5%, and a small risk of hemorrhage or needing blood transfusion, 0.5%. Again, I've just popped up a table. I won't read through all of it, but in terms of comparing medical and surgical termination on some of those complicating factors, and actually the numbers are fairly similar between both groups. So slightly higher chance of incomplete abortion or continuing pregnancy in the MTOP group. And really that's where the importance of follow-up comes in with medical termination. So follow-up is essential, and I'd usually time this for around 2 to 3 weeks after the mifepristone, and this can be done by telehealth. Your main goals at this point are to ensure that A, she did have the expected bleeding at the time of medication, and ruling out that there's any ongoing pregnancy, identifying if there's an incomplete termination or retained products, excluding risks of infection, and making sure that you've done that contraceptive review and checking in with the woman that she's doing okay. So confirming completion. So for all women, I guess we need to see it around that 2 to 3 week mark that symptom resolution has occurred. So thinking about, has bleeding ceased? Have pregnancy symptoms resolved? But then using either the serum beta-HCG or a low sensitivity urine beta-HCG. Now, probably practically speaking, this will mean doing a serum HCG. We do use the low sensitivity urine beta-HCG at the Royal, but it's not readily available. So I'd probably suggest the serum HCG. So with this, it's a comparison between your baseline HCG, which needs to be done within 72 hours of your mifepristone, and then you want to see about an 80% at least decline in that HCG at the 8 to 16 day mark. In terms of the low sensitivity HCG, that can be done if you've got access to it, but it does indicate only that the HCG is less than 1,000. If you do use like a store-bought HCG, they're high sensitivity and they'll detect beta HCGs of 30 or more. So these can remain positive for a month or more. I really recommend avoiding using that high sensitivity HCG and avoiding pelvic ultrasound. Pelvic ultrasound is best used if there is ongoing symptoms or if your HCG hasn't fallen appropriately, but it's quite non-specific. So you often will see that there's possible retained products and it can lead to over-treatment. Okay, so troubleshooting is probably the most helpful thing, practically speaking. So the big sort of that I'd be thinking about would be if there's no bleeding within that first 24 hours after misoprostol. If that happens, it's really important to do a pelvic ultrasound. I'd be thinking about, is there an ectopic pregnancy that's not been seen? That's if they've not already had an ultrasound. If that's confirmed, it is an intrauterine pregnancy, then you can offer a repeat dose. And that can be a repeat dose of the mifepristone and misoprostol, just in the same way that you've done it before. You just need to make sure that they still fall within that 9 weeks and 0 days. Or you can refer on for surgical termination if that's the patient's preference. Next issue is if there's persistent bleeding or cramping at that 14 to 21 day mark. So the main suspicion would be of incomplete abortions or retained products. So a good idea to do a pelvic ultrasound, or you could do a serum beta HCG if you think it's fairly mild. You can offer conservative management as they may expel the ongoing tissue, but I'd be following up with them during that time. A lot of women, if they do have retained products, may need further treatment, so you can refer on to the Royal as well for surgical management. Then obviously the big one that we're worried about, having an ongoing pregnancy, and if we have given the mifepristone and misoprostol, there is a small risk of teratogenicity. So we would usually recommend a surgical termination in this context, but they should have counselling due to a small risk of birth defects if they did decide to continue. I've just included a bit of info about the referral criteria at the Royal. So they are fairly strict. So main thing is that they need to reside within our local catchment area. They need to have either complex medical or social needs or some vulnerability or disadvantage. We see women who are less than 18, financial barriers to care, or if they're unable to access private care due to an advanced gestation or any other issues. As previously, if there's any suspected aneuploidy or fetal anomalies, those women still need to be referred via MFM. Feel free to call our termination coordinator as well. We've got lovely Vicky who is on the phone and quite readily accessible during business hours. Same sort of e-referrals pathway exists. It is really important to please put termination of pregnancy on the referral because it's triaged more quickly, so just so that women can be seen as quickly as possible. Also feel free to call our termination of pregnancy coordinator as well, or send an email. If you are referring to us, if you can, organising an ultrasound, blood group and antibody screen, some baseline bloods, and if you can, a low vaginal swab and STI screen is helpful, but we can organise that if that's complex for the woman to access prior. I've just really included a few resources at the end of the slides here, if anyone wants them sent around, just in terms of some options for pregnancy options counselling. And then also a little bit of information if you did want a little bit of online learning. There's a few really great resources around as well. Great. Any questions?
If you're worried about complications of the medical termination, can you go through the EPAS clinic, or would you call the?
Yeah, so the question was about if there are complications and whether to go through the EPAS clinic. You certainly can. So I guess if someone's having abnormal bleeding, very happy for them to be referred via that pathway. To be honest, either way that they are referred, we could sort them through either clinic. Yeah. And I guess the differentiating factor, EPAS does run every day during the working week, so there's a little bit greater access, whereas the termination clinic just runs every Thursday. So probably, yeah, EPAS is probably the quicker way to go generally. Very good.
I had a patient recently who's, when I did the ultrasound, the dates weren't concordant with her last menstrual period, even though she had regular periods. And there was no fetal cardiac activity. So I thought it was a missed miscarriage. So I referred her to EPAS because I wasn't sure if it was appropriate to give medical termination in that instance. Was that the right thing to do?
Yeah, look, I guess so the question was about referring a woman to EPAS who had a scan that was not concordant with dates and no fetal cardiac activity. So essentially, it looked like it was behind and probably a miscarriage. So that's appropriate. Very happy for them to be seen through EPAS, and I think the service is quite nicely set up for that. Having said that, the EPAS, would offer medical management for that woman, assuming she meets other criteria, and we can use misoprostol or a combination of Mifi and miso being more effective, actually. So, yeah, I guess depending what you feel comfortable with. Yeah, well, I guess it's at that point it is management of miscarriage rather than a termination of pregnancy, but the medications are the same. Yeah.
Thanks so much, Maddie. When we're making decisions regarding a suspected continuing pregnancy and a repeat dose of MS2 step before that 9-week period, are we making that decision based on an insufficient drop in the beta-HCG, or do we need to confirm with the repeat ultrasound to say that it's continuing at that point?
Yeah, so the question was in regards to giving additional treatment for ongoing pregnancy or suspected ongoing pregnancy after MS2 step. I think if you're concerned about that at the, say, 2-3 week mark afterwards, which is where you might see that there wasn't a sufficient drop in the HCG, I'd do a scan at that point. Yeah, particularly because the amount of time that's passed, it'd be helpful to see, well, has this pregnancy been ongoing? You're probably going to fall outside of that 9 and 0 cutoff as well. So I think it's probably a good idea to check in on that. Yeah. Yeah, I guess the time where you would be more likely to be giving the second dose of MS2 step is where they've taken the medications, it's been 24 hours, nothing's happened, or they've had less than expected bleeding. Then I'd be thinking, well, if you've already got a scan, you already know that it's intrauterine, I'd give them another dose. If you don't have that, that's where you go down that pathway of doing a scan. Are we missing something before you consider another dose? Yeah. Yeah, so the question was in regards to the New South Wales health forms for registration of termination of pregnancy. Yeah, so we do need to do that to register any termination. It's de-identified, so there's no patient information that goes into that, but yeah, that is needed. So, and that's very readily accessible online. Sounds like afternoon tea time.
Just say a quick thank you, Maddie. That was really comprehensive. Hi, everyone. If we can get everyone seated and ready for the next talk. Our next talk, everyone, is going to be about smoking, vaping, alcohol and other drug use, how to support cessation in pregnancy. And this will be presented by Dr. Hester Wilson and Isabella Jreige. Dr. Hester Wilson is a GP addiction specialist and chair of the RACGP Addiction Special Interest Group. Hester is a clinician with many years clinical and teaching experience. She is medical advisor for the CESLID Population and Community Medicine, Chief Addiction Medicine Specialist for New South Wales, and a member of the RACGP Expert Advisory Group on Tobacco and Nicotine Cessation. She's an experienced facilitator and medical educator, and she is keen to ensure access to credible, evidence-based information for GPs and patients to assist nicotine and smoking cessation. Isabella is a health promotion officer within the Equity and Prevention Service Population and Community Health of CESLID. Isabella leads the Preventative Healthcare in Pregnancy program across district-wide maternity services with a strong focus on supporting healthy lifestyle behaviours among expectant mothers. Her work centres around promoting healthy eating and physical activity, as well as supporting smoking, vaping and shisha cessation during pregnancy. Isabella collaborates closely with multidisciplinary teams across maternity services to embed evidence-based prevention strategies into routine care, improving health outcomes for women, babies and families across the district. Please welcome Hester and Isabella.
Well, thank you for the lovely introduction. So before we start, we would like to do an acknowledgement of country. So Southeastern Sydney Local Health District acknowledges Aboriginal and Torres Strait Islander peoples of the Dharawal, Gadigal, Widjigal, Gidjigal and Bidjigal peoples of the traditional custodians of the lands and centres that we operate on. We pay our respects to ancestors and elders past and present. CESLID is committed to honouring Aboriginal and Torres Strait Islander people's unique cultural and spiritual relationships to the land, waters and sea and their rich contributions to society. We also acknowledge people in our communities with lived experience and living experience of drug and alcohol use and those who love and care for them. We recognise those who have been lost early and their impacts on families, carers and community. We recognise their right to dignity and safe, accessible, equitable, non-judgmental and quality care.
Thanks, Bella. I want to say hello to everybody. And also, I understand there's about 200 people online, which is really, really brilliant. I want to tell you about Angeline. Angeline is a real person. These pictures are online, and Angeline has been a very strong advocate as a biological mum of a child who has FASD. And the reason I want to talk to you about her story is, as she says, the mother's guilt is intense. All mother's guilt is intense. But this was amplified immeasurably every time I looked at this amazing and vulnerable little boy. So she had alcohol dependence. She didn't know she could become pregnant. She was told she was infertile and she didn't find out she was pregnant until her second trimester. And she went to a doctor and said, look, I realise I'm pregnant. I want to do the best for my baby. I have a real problem with alcohol. And the doctor said to her, you're an addict. I can't help you. So she continued to drink through her pregnancy because she had a dependency and it's not easy to stop. She did everything else she possibly could do. She made sure she ate well and did everything to ensure that her baby was in the best possible health and she was in the best possible health. But she didn't stop drinking because she needed someone to do more than say, you're an addict, I can't help you. And thinking about her son is now grown up. And the issue with being a person that has FASD, that is a lifelong disability, that is totally preventable. So really wanted just to put that human story behind what we do in general practice setting every day and the difference that we can help make to people's lives. I also wanted to just point out there's some really good news, and I can hardly read this because it's really tiny. It's probably bigger on the screen there, but this is from the Australian Institute of Health and Welfare from 25. So we're looking at what has happened over a 10-year period. And what you can see is the number of people who are not using tobacco, alcohol or illicit drugs has gone up. And the people who are using alcohol and tobacco has gone down. So we're seeing really good changes with time. And that is in pregnancy, I should say. In 2023, 5.6% of mothers in major cities were smoking, whereas a third of mothers in remote areas were smoking. And this is older data, and this is the newest data I could find up until 2017. More than about 1.5% of children were exposed to at least one substance during pregnancy and nearly 3% post-pregnancy. So they were very likely to be women that smoked, that drank, that used other drugs. Prior to pregnancy, and this is a study done on data from 2018, nearly 80% of women were drinking, and the vast majority of them stopped when they found out they had a pregnancy diagnosis. 50% who continued drinking did so only on special occasions, whatever that means, and 78% were aware of the recommendations that and at this time, it was the NH and MRC recommendations which said it is best not to. After this data was collected, they actually updated that to say you should not drink alcohol during pregnancy. So And what we see here is that, interestingly, the very low socioeconomic and the very high socioeconomic have higher rates of alcohol use in pregnancy. And Aboriginal women, 46% of them were smokers, and this is in comparison to at the time this data was done, about 15% of Australians. 46% were smoking and 20% of them quit with pregnancy. 21% were drinkers and 60% of those quit with pregnancy. 15% used cannabis and nearly half of them quit with pregnancy. They were less likely to quit if there were multiple substances. So what this tells us is that there are a group of women who continue to smoke, continue to drink, continue to use substances, and that this is an issue for them in pregnancy. And if you have doing more than one of those behaviours, you're more likely to continue, and it flags that there is other complexities going on. You may be living in a house where there's poverty, where there is intimate partner or family violence, where there is mental health issues, where there are other health issues. So it is still with us, though the majority of women that we see don't smoke or don't drink or stop when they find out. There is a real issue around that group of women who don't realise they're pregnant and stop drinking as soon as they realise they're pregnant, that there's still a risk for harm when they are pregnant and don't know it. So just in today, what we wanted to do, and because the Antenatal Shared Care Committee said this is what we want you to do, everything you ever wanted to know about drugs and alcohol and tobacco during pregnancy. So we're going to do that in the next 40 minutes. But we're looking at non-medical use of nicotine, and that includes cigarettes, tobacco and e-cigarettes, alcohol, cannabis, whether it be medicinal or not, opioids, whether it be prescribed or not, stimulants, whether it's prescribed or not, and pharmaceuticals. And in there you could also put some of the other less common things like nitrous oxide and GHB, for example. But also the medical use of substances, be those opioids, benzodiazepines, antidepressants, gabapentinoids, antipsychotics, that they are an issue as well. And the issue with pregnancy is that even low level or infrequent substance use that does not meet the threshold for problematic use may have consequences for an infant's health and development. So when I'm talking to people that aren't pregnant, it's a different kind of risk profile. And if people choose to live their lives and to use drugs and alcohol and smoke, hey, that's their privilege, that's their right. But when it comes to pregnancy, the bar gets higher because it is so harmful for the developing fetus. So with tobacco and e-cigarettes, nicotine is bad news. Stillbirth, early labour, small for dates, intrauterine growth retardation, increased risk of sudden infant death syndrome and neurodevelopmental impacts. With the tobacco, you've also got carbon monoxide, which is harmful in itself, and carcinogens, heavy metals, all the other 4,500 polyhydrocarbons that are in tobacco that are so harmful. And with all the other drugs, you've got specific drug effects, and I've mentioned the FASD, the effects of intoxication and withdrawal. So if you imagine somebody who's using heroin and they're becoming intoxicated, the baby is becoming intoxicated as well. As the dose drops down, they withdraw and the baby withdraws. That intoxication and withdrawal cycle, and it's the same for alcohol, same for other dependencies, is actually really harmful to the baby's neurological and biological development. There's also the effect of dependence, as we talked about with Angeline, that because you are dependent, one of the things about it is you cannot control. You can't stop just because you want to. And there is also the issue that happens with withdrawal during pregnancy, but also when the baby is born. The general, and there's a lot of them, but I've just kept this very general due to time, from the other drugs, apart from nicotine and tobacco, placental abruption, early labour, low birth weight, still birth weight, and neurodevelopmental impacts, just to keep it broad. With prescribed medicines, there are some of these risks as well. And as we know, it really is looking at that balance of the risk versus the benefit. And absolutely there are times when women do need to be on medications. Ideally, we don't want them to be on anything, but there are times when we do. And so it's really looking at the balance versus the risk. And diagnosing dependence is important. And it can be a tricky thing for us to diagnose. But thinking of Angeline, the doctor saying you're an addict, he kind of diagnosed it, though calling someone an addict or calling somebody saying you've got an addiction is not a diagnosis. But it's really being clear. Is this something that this person is able to change for themselves? Are they confident they can do it? Is it important for them to do? Can they do it themselves? And if not, what support do they need? People don't disclose their use. It's easy to understand why, particularly in pregnancy. If you're doing a behaviour that you know is harmful to your unborn child, it's really hard to fess up to it, and you can feel really shamed. At the same time, it's a really fabulous time to make change. Women don't want to harm their babies. Doesn't matter what your complexity of your life is, you don't want to harm your baby. And so thinking about the things that get in the way of people disclosing. So there are a lot of them. There's a lot of reasons why people use substances, but certainly if we start looking at, occasional use at a party or, heavy use or dependent use, there are lots of reasons why. But people don't disclose. They don't realise that it's something that's treatable. They think it's a moral failing, or it's just because they just don't have the strong will, that it's not something that they should need help with. Treatment doesn't meet their needs. They're worried about confidentiality. They don't realise they have a problem. There are cultural barriers, so services don't actually meet the cultural needs, whether someone's First Nations or culturally, linguistically diverse background. A complex history, a lot of other stuff going on, and I'm sure you've had this the same as I've had when you see someone and they've got all this stuff going on in their lives, and it's like the substance use is important, but so's the housing, so's the domestic violence, so's the fainting episodes that they're having at the moment. There is so much going on. Just keeping their heads above water. They're just trying to keep going and trying to manage their lives. They may well have had bad experiences of health services. Another big one is if you have been a drug user, that you can internalise this stigma and believe that you don't deserve good care. Not ready to make the change. Their use meets a need. It is always rational. Stigma and discrimination. This is a really nice handout from NADA, put together with people with lived and living experience, and just talking about the language. So being careful with the language, because language does impart stigma. And if you're feeling really shameful about what you're doing, being told you're an addict does not help you to engage with treatment. So it is available on the web. But things like abuse, misuse, which I hear all the time, not particularly useful words to use when you're talking to people who are using drugs. Dirty, clean urine, addict, druggie, alcoholic, in denial, resistant. They're all terms that actually are not particularly helpful. And so they suggest trying things like a person who uses drugs, a person experiencing drug dependence. Just like these days we tend not to talk about the asthmatic or the diabetic, the person living with diabetes, the person living with asthma. Once again, it's not who they are, it's a part of what's going on for them. And being aware of our language, trying to, as much as you can, use non-judgmental language is really important. And I can't tell you the number of times where I've said something and I've realised that the person's kind of gone, oh, geez, what did I say? So it's okay to check in with people and ask, I'm sorry, it feels like you've taken a step back, or I've said something. Let me know, because I'm here as your healthcare worker. I was your doctor, your GP. I really want to help you, to achieve the life that you want to have. So, which comes to asking. So, we've got the 5 A's, which I can never remember from the SNAP guide. Ask, assess, advise, assist, arrange. Is that it? Something like that? Yeah, okay. They've cut it down to 3, which is much easier. I don't know about you, but I can even remember 3 and other. So the first one is ask, and really explaining why you're asking and asking permission. I've never had anybody say, no, I don't want you to ask. People sometimes don't understand why we're asking, or they can become concerned that we're asking. They may not realise that it's part of our role. But thinking something like, as your GP, your health and well-being and that of your babies is what I'm here to do. I'm here to help out. Can I ask you about behaviours that might impact? For example, your nutrition, your exercise, your stress, your drinking, your smoking, your gambling. The list of things that we want to know that can have an impact on people's lives. And as I say, I've never had anybody say no. I have had people say, yeah, Hester, I've got to go and pick up the kids and you're running an hour late, because I usually do. Can we do this next time? So, but people, explaining why and asking permission, people are happy to tell us what's happening most of the time. They may not tell us the full story. But as GPs, we are deeply trusted by the people that we see. And we see people over time, and so we can develop that trust as well. Do you smoke, vape, drink alcohol, use other drugs, or have you recently quit? The recently quit is really important, particularly if you're seeing people planning pregnancy or pregnant, because you really want to say, that is amazing, fantastic that you've changed that. Congratulations. Really good thing that you've done for your baby. Keep up the good work. If you find that you're starting to slip back into some of those behaviours, come and see me, because we really want to make sure that you can maintain that change. If they're still using, for example, with smoking, the most important question that you can ask, I remember in the old days we were always, it was like how many pack years and how many cigarettes a day. The most useful question that you can ask is, how long after you wake do you have your first cigarette or your first puff? It's a really good proxy for the level of nicotine dependence. Are you using every day? Are you needing more than you needed to? So in terms of asking about substances, so with alcohol, do you have a drink? How much do you drink? When do you drink? Do you ever have more than 6 standard drinks in a day? So there's those 3 questions in pregnancy that if it's more than 0, basically you start to get some risk. Looking at tolerance withdrawal, do you find that you need to take more of that to get the same effect? When you stop, what do you notice? Do you start, for example, with alcohol feeling shaky? Do you start with your puffer, your vape, just feeling a bit antsy and wanting to grab that vape, to give you a sense of yourself, a sense of the level of tolerance? How much does this take up? What is the salience of this? When I'm talking to people, I say, well, is it your number 1? And they'll go, yeah, it's become number 1. Well, no. How much time do you spend getting the substance, using it, getting over it? Oh, about 20%, about 80%. It gives you a sense of how much it's taken over their lives. And can you change it if you want to? And people will say, I don't know, I haven't tried, no, I find it really hard. Or they say, well, I can stop. And this is just to remind myself, the social determinants of health as well as the commercial determinants of health, we do need to be aware of those. And as I was saying before, people living with complexity, living with poverty, living with violence, living with access to healthy food and exercise, and all those kinds of things are really important. And that potentially will depend on where you work. I'm going to hand over to Bella, who's going to tell us all about carbon monoxide monitoring.
So like Hester was saying, we know carbon monoxide in pregnancy can be quite harmful for not only the mother and the baby. We wanted to let you know in South Eastern Sydney Local Health District, but also Sydney Local Health District, carbon monoxide monitorings. So the monitor looks like this, is offered to all pregnant women regardless if they're smoking at their first booking appointment, as well as at 28 weeks gestation. And this is based on a New South Wales health policy and a policy directive. So the midwives at the Royal Hospital for Women, for example, offer this at their booking appointment and at 28 weeks. If a woman has disclosed that she is smoking during pregnancy, this monitoring test is offered at every appointment throughout their pregnancy journey. And it's really to be used as a motivational tool to show on the monitor the level of carbon monoxide in the blood and also the carbon monoxide levels that are being passed through the placenta to the baby. We also understand that this monitoring device, most likely GPs don't have access to this at their practice, and you may get women through antenatal shared care coming to you and telling you that at the hospital I was offered this test and this is the result I got. You can see on the screen it's like a traffic light system, and that the results are different from adults to adolescents and in pregnancy. Women might tell you that they had a low reading, which is a really great sign, but they might tell you that they've got an amber reading or a red reading, and that indicates to you that there's higher levels of carbon monoxide in their blood, and that conversations can happen at your level to support reducing that carbon monoxide in the body. And Hester is going to talk about how we can do that.
Thanks, Bella. I think that one of the things when I heard about the policy was I just really wanted to ensure that all of us in general practice were aware that this was happening, because there's nothing worse than when someone comes in your room and says, I've had this test, and you go, huh, Okay, I'll look it up on Google. But the other thing is that carbon monoxide monitoring is positive not just if you're smoking, but it's also for passive smoking, but it's also environmental exposure. So unflued heaters, people doing things like using a gas barbecue indoors because their cooker's broken, those kinds of things, so that those can raise it as well. So it's a really good indicator of exposure, and if the mum's being exposed, the baby is being exposed. If you have a cigarette the moment before you do your carbon monoxide monitor, it will peak it. So, ideally people do it 10 minutes before, and it will start dropping after 8 hours. If you change the amount of tobacco or that you're inhaling, after 8 hours, if you stop it, it will go down. It very quickly drops. So it's a really nice kind of biofeedback around change. I want to flag though, if somebody's vaping, this doesn't show, because what you're doing with vaping is you're inhaling nicotine, not tobacco. Okay, so we get the asking, we get the advising, we get the help. So that's the new mnemonic now, down from the 5 A's. I have to say, every time I think about this, I think to myself, yeah, that's what we do in consultation all the time, so we might call it this, but, it's a nice little thing to think about. As I said before, in pregnancy is a great time. People do want to change. And if people don't change, there are really good reasons why. First of all, checking out, are they aware of the harms? Now, sometimes I don't spend very much time talking about harms because people know, and doing a whole lot of, are you aware that it can damage, blah, 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 finger, wagging, just actually doesn't help people to engage and change. But it may be that they don't realise, for example, with vaping, that carbon monoxide is damaging. And the carbon monoxide from tobacco is damaging, and also from vaping, the nicotine itself is damaging. You're putting your hand up the back there. Sorry, I think I bumped it. Is that better? Oh, that's no good. Like here. I love it. I feel like I should be singing a song. Sorry, you should have said hours ago, mate. Okay. So are you aware of the harms? And if they have made change, don't forget to congratulate, because it's a big thing for people to make change. The other thing is cutting down. So there is a place for cutting down. I have to say, though, with smoking and with vaping, people will talk about cutting down, well, particularly with smoking. I've only had 5 cigarettes, but I tell you what, we are so clever. If you're a smoker, you can smoke, you change the topography of smoking and you will smoke so that you get every ounce of smoke out of it. And so you can still have a really high CO. One of my patients was smoking 5 cigarettes a day and managed to have a CO of 90. Like, he was so efficient. It was like, oh my God, you are so efficient with your smoking. So he'd come down from 20 a day to 5 and was feeling so good about it. But in fact, he just got more efficient, so he was doing the real drag back. That's show me how you do it. So cutting down is good. Ideally in pregnancy, we want abstinence from everything. It is not always easy, as I say, and just telling someone to stop may not be enough for them. So they may need to seek help, and once again, if they're dependent, they will need more help. Okay, so this is just a little thing that I stole from a guidelines. This is really weird, this mic. The Ask, Advise, Help model, just to flag that it's not just me making it up, it's actually written up by clever people. But in pregnancy, ask all women about current and previous use. Discuss, it's better for you not to. You really should change this. And the risks of using in pregnancy if they're not aware of them. And offer support. So we're dividing it up into basically 2 things. One's the smoking and the other is all the other drugs. Because we have substance use in pregnancy and parenting services that deal with people who have more complexity, who are using more than one substance, who are very dependent, who find it hard to change. So I'm not expecting that you guys in your busy GP day are going to be able to, as well, physically able to, because you just don't have the time and the support to support someone entirely who has a complex dependency and complex issues going on in their life. Okay. How are we going for time? 15 minutes, oh my God. Okay, so first of all, with nicotine, smoking and vaping, what we know works is behavioural interventions and NRT. And I know we're always really anxious about using any drugs in pregnancy, but if somebody is smoking or vaping, they are better off using a prescribed first-line NRT than staying on the smoking or the vaping. Certainly in the College of GPs, we have put vaping as a second-line option for smoking cessation, but not during pregnancy because it is still harmful. The nicotine is still harmful in pregnancy. And you know, we know that the best way to get people to stop smoking, the one with the most efficacy, is behavioural interventions and your short. So that's your lozenge, your spray, your gum, and your long-acting, which is your patches. Putting all three of those together give people the best chances of stopping smoking. In pregnancy, bupropion and varenicline are not currently indicated. There are some studies looking at women who just happen to stay on these medications during pregnancy, but it's not something that we would start. Okay, so RHCGP kind of hedged its bets by saying if you're using NRT, the benefits and risks should be explained carefully to the patient. And the clinicians supervising the pregnancy, so the antenatal shared care, the hospital should also be consulted. So thinking about how you would do this. So when I see someone, the history is really important. So understanding time to first puff or first vape, how many a day gives you the level of smoking dependence. But if for vaping, it can be really hard for people to work out how many puffs. Sometimes they can work out how much juice they've got and what percentage nicotine is in their juice. But the illicits, God knows how much nicotine is in it. It's very hard to know. So I would just say puffs. How long after waking do you have your first puff? And put together a score, which is if it's within 5 minutes, within 30 minutes, within 60 minutes, more than 60 minutes, decreasing levels of dependence. So you might start with someone who doesn't have their first cigarette or puff within the first hour of waking. You might go, let's just try behavioural. But I want to see you again because I want to make sure that you're able to change this. We might try behavioural and some short acting because we do want to limit the amount of nicotine that women and their babies are being exposed to. But it's always got to be this benefit risk in comparison to someone who is smoking or vaping and taking in nicotine and carbon monoxide and all the other stuff. They are better to be on medically managed NRT. So with the group of women that I see, I start them on long acting. I give them the short acting and we do the behavioural management as well, and I follow them up really closely because they're highly dependent, they need lots of support. They desperately, desperately want this to be different and it is really hard. The other thing that we do is we engage with the household. So if they're smoking, it's really likely that other people in the household are smoking. And so either they need to go away whenever they smoke, change their clothes when they come back into the house to decrease the secondhand smoking, or even better, they take on the challenge of changing their smoking as well. So you can see there in those graphs, which I've taken from the smoking cessation guidance from New South Wales Health, just a bit of an idea of how you might build that up. But if you've got someone that says, I am waking and I'm having my first vape or my first cigarette within 5 minutes of waking, I've got my rolly rolled up on the bedside and I light it up before I get out of bed, highly dependent. I've tried with behavioural, I've tried with the gum, it doesn't work. I'd go straight to combined NRT and behavioural and lots of support. Okay. In terms of managing alcohol and other drug use in pregnancy, this is a huge area which I'm just going to very briefly cover. We want women to stop completely if they can. Asking them, can you stop? Can you do this on your own? Do you need support? I really want to support you because we absolutely want you and your baby to be as well as possible. And it's okay to need help to do this, and there is good help available. As a GP, you're probably not going to be able to offer all that help on your own, but you are super important as part of the support team for that change. I am here to support you as your GP. And these are the people that you would help to engage with your substance, SUPs, group, which is the Substance Use in Pregnancy and Parenting service that we have here in Southeast Sydney and in Sydney Local Health District and all around the state. And really supporting women to take that step to engage with those wonderful workers in the subs teams who are very experienced counsellors, nurses, doctors, health education officers. They're great teams, paediatricians, obstetricians, who support women who have more severe drug and alcohol use. So you wouldn't refer someone to subs if they're just smoking, but if they're smoking and using cannabis, smoking and using alcohol and unable to change that, or finding it tricky to change it, or other drugs, absolutely. If they are using pharmaceuticals and you're worried about the risk, those are ones where they can get involved as well. So here they are. There are good clinical guidelines. Once again, I'm not expecting you guys would want to read these, but they are freely available on the web if you want to take a look. And really thinking about who are the people that we want to refer. And we'll move on to it. So who to refer, it can be pre or postnatal or a child in their care up to 2 years of age with current or relapse risk to substance use. So they can be someone that's been doing really well but comes back saying, I am just, I've got this newborn baby and I am just thinking about drinking 24/7. I am worried I'm going to change, I'm going to start, or I have just started again. They can help. They are really, really terrific. It's a voluntary service. It's, we don't compel people to come. And one of the things is to have the conversation with the woman and make sure it's a warm referral so that they're aware that you're making that referral. It's really tough if they're referred without knowing, because then our service rings them and they say, why are you ringing me? It's, oh, so your GP didn't tell you. Please, it's part of what ensures that helps women to actually take advantage of that service. And I have to say, they are brilliant. Having worked alongside them, they can make a huge difference, support women. They go to their antenatal visits, they support them out into all the other areas of their life to help them to have as healthy a pregnancy as possible. One of my patients who was extremely unwell with lots of drug use found out she was 6 weeks pregnant, and for her pregnancy actually stayed in a rehabilitation unit, Jarrah House down in Little Bay, and then after the baby was born, went to Phoebe House down there in somewhere down south in our area to really help her to maintain her abstinence from substances. She was started on treatment for opioid dependence, really important. That one is a good one for people to be on. But to refer, at the moment, it's central intake, or you can page the subs team via switch. I did this the other day just to check that it's actually real. So I actually rang and said, can I talk to the subs nurse? Got put through, had a chat to the subs nurse. Or you can do it through maternity, and the maternity social wipe is what they suggested. In Sydney, you have an email address. Now, what I've realised is that neither of these referral options are on health pathways, so I've asked both Sydney and South East Sydney health pathways to actually link to the sub services, because it's really important that you guys know. And all the time I'm thinking of people like Angeline, who, if she'd been offered the support that she needed, might have had a really different trajectory, and her son might have had a really different trajectory. Okay, I'm going to hand back to Bella.
Thanks, Hester. So very briefly around Quitline. So as you hopefully all know, Quitline is a free service to support patients with smoking cessation, and that can be during pregnancy, but also postnatally. That's just not also with smoking cessation, but also vaping or patients who are smoking shisha. Really important to know that these Quitline counsellors cannot prescribe NRT. So it's important that when you're having these conversations with your patients, that you're the one prescribing the NRT, but these counsellors can support of how patients actually take NRT and making sure that that happens whilst potentially you're not always there to check in. These counsellors also provide resources and support and tailor that information to the patient's situation. And there's also the PAVE app, which is around vaping, as well as I Can Quit, which they take them through to make sure that they have all the information to be able to make changes in their life. You can refer to Quitline through the phone number at the top, or this is also in Health Pathways where you can send a referral form. In terms of the Get Healthy in Pregnancy service, so this is a free New South Wales health service.
You might need to be a bit closer.
Which offers a healthy lifestyle program to not only women who are pregnant, but also postnatally and their families. This is a free service with university qualified health professionals. So they'll be speaking to either a dietitian, registered nurse, or exercise physiologist. And particularly within this presentation, they support with alcohol abstinence in pregnancy, but also can support in other areas such as healthy eating, reaching and maintaining a healthy weight in pregnancy, also gestational diabetes, as well as physical activity. And you can refer to this program through Health Pathways, as well as Medical Director and Best Practice.
So that's it from us. What are your take-homes, Bella, if you're thinking about what you want people to take away from today?
I think just knowing what the referral pathways are, and that if you do need support as a GP, you do have access and support to help your patients.
Yeah. So I think for me, it's around ensuring that this is a time of change and a time where women are really wanting to do the best by their unborn child, and asking permission, explaining why, and then taking a history. And then, really thinking about particularly the smoking, so you can use NRT in pregnancy. I know we're anxious about it, but do use it for someone that is having problems stopping smoking. It is much worse to continue to smoke or to vape than it is to use NRT. Don't just give it to them and say, you'll be right. They're going to need support. So Quitline, your NRTs all together, and you continuing to see them, or your nurse continuing to see people to make sure that they've been able to make that change. And if you've got someone that cannot stop their alcohol or other drug use, the SUPS teams are there. They are brilliant. They can make a real difference. So that's our Dr. Kerry Chad, who's the Chief Health Officer for New South Wales, and her little saying there. And that's it.
Thank you. Hester, I had a quick question, hopefully quick, but how, if someone's vaping, what's your way of managing with NRT and to try and get them off vapes?
We have no evidence around how to do this. And that's one of the problems with saying, hey, let's use vapes to stop people smoking, because we don't know how to get them off the vapes. But what I find works is so much of it is around the therapeutic engagement that you have with someone and supporting them to make change. And so you may start, let's try you on short acting. And we're not even going to set a quit date. Let's just try it and see what that does to the amount that you vape. Has it changed the way that you vape and the amount that you vape? Or do you want to go for a patch? Or do you need 2 patches or 3 patches? I sometimes will use 3 patches with people that have very high dependency. And sometimes they might get a bit nauseous, so I might pull back then to 2 patches. But, the reality is that you want to give people an experience of successful change. So it really depends on that person's history. Have they tried before? And really common for the people that I see to say, look, quite frankly, I'd really like to stop, but I've tried and I can't. So what have you done? What have you tried? Oh, I got some gum from the pharmacy and then I got a patch from the pharmacy and it didn't work. So the thing about how you do it is, you've got time. Well, in pregnancy, you want it to change quickly, but you do have time, and we need to work with people as individuals. And so let's call the Quitline. Quitline is amazing. They're really good with vaping as well. They've done a whole heap of training and they really manage that very well. And in young people as well, they're really great at it. But then add in your short acting. What has changed? Let's keep an eye on that. I want to see you next week. And what we'll do if that hasn't changed, let's start a patch. And if that doesn't work, then let's go to 2 patches. But it really depends on the level of dependency that someone has. And the carbon monoxide, I know most people won't have it in your general practice, but if you've got a woman that comes back and says, they told me that I had a CO of 50, that is massive. It's really massive. And they will be the person that has their first cigarette on waking and smokes throughout the day. And so with them, you'd want to use a higher dose. So it's not quick and easy, but it is like any behaviour change. When you think about it with alcohol, with exercise or changing your diet, it takes time. You've got to work through it and look at what success they've had in the past and how you can help them overcome the barriers.
Can I just ask about that CO2 monitor? Was that happening for all women that have been in the shared care program? Because I just had a lady who just had a baby, and like when you were saying, Hester, about if the lady hands you this piece of paper, you don't know what she's talking about, and you have to sort of Google it. So I haven't even seen it. So when did that start? That program, and is it for women that are pregnant at the Royal that are doing shared care, or is it only midwifery care, or who's?
Yeah, so it's for all women accessing public health care within antenatal outpatient clinics. So antenatal shared care patients, so definitely being offered this carbon monoxide monitor. But of course, they can decline if they don't feel comfortable doing this. We're working very closely with our midwifery team, not just at the Royal, but across the district to support midwives to offer this monitoring test. But definitely you can have conversations with your patients around CO monitoring if they don't mention it, and then to bring that back into the hospital for them to then have access to this monitor. Yes, so everyone should be offered it at their first booking appointment as well as at 28 weeks in relation to the policy directive. That's a really good question. Let me have a talk with our midwifery team and see how that's documented back to yourselves.
Question online about what is an acceptable level of CO on the monitor, and I believe the slide said for green it's 0 to 3, but then is that correct? And then there were different levels for amber and 0 to 3 for adolescents and pregnancy, and then 0 to 6 for adults. But then there's different levels. But I feel like as GPs we wouldn't need to know exactly.
So most of us living in Sydney have a CO of around 2 or 3. If you live on a busy road, it might be 4 or 5.
And another question here.
This might be beyond the scope, but is it a $500 machine? Is it much more? Do we want to globalise this for our other, well, unfortunately we can't do it for the vapors, but, for the other people that we're trying to track, or is it only useful for 10 minutes before and 8 hours later it's out of your system?
It's a quite expensive machine, to be honest. They're around $1,000 a machine. They have a 5-year warranty. So within our maternity services, every clinic has access to multiple machines. But yes, they only have a 5-year warranty. And if you are only seeing a few patients within antenatal care, we understand why GPs wouldn't have access to one. But if you definitely wanted to invest in one, we can, support with what that looks like.
And it's great for anybody that's smoking, so honestly, it's a really great one for people who've not been able to stop before. So you say, okay, so this is your CO today, it's 50 today, let's do some stuff, let's get you started on the patch, let's just see what happens. Don't even try to stop smoking. Let's just get some nicotine in your system that's safer. And they'll come back and you go, it's 30. You have cut down the amount of carbon monoxide in your system by almost half. Oh my God, that is amazing. So it's a really nice biofeedback. So really supportive of you thinking about it for your general practice, but you'd want to be working in a practice where you use it quite a bit.
At what stage in the pregnancy are they tested? Like on the shared care program?
Be at their booking appointment, so their first appointment that they come in to access to antenatal outpatients, and roughly around their 28-week gestation.
The other thing is, of course, you want women to stop earlier. than their booking appointment. So that's a really important role that we have in general practice, when people we find out they're pregnant, to have that conversation earlier. The other thing is that at the moment, I think I've got this right, maternity is doing carbon monoxide testing, but they do not have the capacity to hand out NRT. So they will be encouraging them to come back to you guys to have treatment. And as Bella said, Quitline cannot provide NRT. It's a really common thing that they get, people saying, oh, my GP told me to come so that you could help me stop smoking, give me NRT. They're not prescribers, they're counsellors. They're really good with behavioural stuff. We're good for the medications.
Thank you. Thank you so much for that excellent talk. We've always learned so much from you guys. So thank you. So last talk of the day. Well done, everybody, for getting to here. I'd like to introduce our next speakers. Our next presenters are Dr. Meredith Stone and Robbie Solomon from the Perinatal Mental Health Service at the Women's. Meredith Stone is the head of perinatal psychiatry and women's mental health at the Royal. Clinically, she divides her time between the Royal Hospital for Women and working as a fly-in, fly-out psychiatrist, managing a broad range of acute psychiatry presentations in the New England northwest area of New South Wales. She's a passionate speaker and educator who has presented on a range of topics related to women's mental health, both locally and internationally. And Robbie Solomon is a registered nurse and midwife and is the clinical midwifery consultant on the perinatal mental health at the Women's, Perinatal Mental Health Service at the Women's. She's got a keen interest in research to provide the best outcomes for women and their children, especially providing person-centred, compassionate care to those with higher biopsychosocial and mental health needs to optimise their confidence in parenting life. She's been working in the field of perinatal mental health for several years and has a postgrad diploma in PIMS. Please welcome Meredith and Robbie. Thank you.
Try and get the, okay, is that working? Yes. So I'm Meredith. I'm going to be doing most of the slides, and then Robbie will jump in at the end to let you know about the services here and how to refer to us. I'd like to apologise first up if anyone was here last year, because these slides are pretty much the same. However, there's quite a lot of content and we didn't get through it last year and we won't get through it all this year. So I'd be very keen for an interactive lecture and for you to let me know what you are most interested in and where you need the most help. I'm going to start, I think, with the same question I started with last year, why perinatal mental health? And once again, I will play a quick video for those who have not seen it as somewhat of an answer.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. the baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, come on, why aren't we doing this? Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Anyone seen that before? Yeah. Is it part of GP training? No.
Maybe med school.
Med school, yeah. I mean, I still, even though I do this lecture quite a lot, I still find it distressing watching that baby when the mother just goes blank. Oops, I'll just keep going. Yeah, so thank you. So yes, I think that's probably one of the most compelling reasons for perinatal mental health. As I always say, because I showed that to the medical students as well, if you imagine what it's like for that baby, if a mother is blank for, 1 minute, imagine what it would be like for the baby if the mother were blank all the time and there were no other primary caregiver who is able to interact with that baby. Okay, so I've given you the reason why we're here. In terms of what I'd like to cover today, or I guess put out there as options to cover, I'd like to just go over the key concepts of what perinatal mental health is, the types of mental illness that we see in the peripartum, just a little bit about normal transition to parenting, peripartum depression, which is probably the thing you see most of, or at least I guess a condition that is that it receives a lot of attention. There's also peripartum anxiety, bipolar disorder in the peripartum, postpartum psychosis. Oh, sorry. Can you hear me when I'm just talking like this? Is that better? If I'm, yeah? No? Oh, okay. This is better? Yeah? Okay. Personality disorders. Sorry, I need to try and control this whilst talking in the microphone. Birth trauma. I don't know whether you've heard much about birth trauma recently. There's been quite a lot in the media. Notes on child protection. Little bit about fathers and perinatal mental health, which is also a huge topic. And then Robbie will present on our service here, and then we'll just hopefully have a little bit of time for some questions. But as I said, please jump in as we go, because I want to tailor it to what would be useful for you. Okay, so perinatal mental health. What we mean, like what is the timing? It's got various definitions, but generally we talk about the antepartum, and then usually about in this service here a year postpartum, but the PIMS service will take women up to 2 years postpartum. Sorry, the microphone is a little bit disconcerting. So we used to, I guess, focus more on postpartum depression in particular, or postpartum mental illness, but increasingly we've recognised that there's a continuum between the antepartum and the postpartum. And therefore, if we get in early, then we can actually often prevent extensive postpartum mental illness. The other aspect that is really important is that it's not just the mental health of the mother, but the mental health of the infant. This is a question I give to the medical students, but I'd just be interested from the GPs as well. How can you determine a baby's mental health? How interactive? Yes. Yeah. Happy, smiley. Sorry. If they're thriving, yes, that's obviously something very relevant to GPs. So they don't have words to convey how they are going, so they have their body, and that can either be in the facial expressions, whether they're crying, but also in whether the body is, developing the way that it should be. Of course, the thing that all new mothers will talk about, or new parents, sleep. That's also an indicator. But of course, poor sleep doesn't mean poor mental health for the baby. And then often also if there are conditions such as reflux or a very unsettled baby, then it's always worthwhile also speaking about the mother's mental health to see how that unit is going. Okay. Mental illnesses in the peripartum, just a reminder that any mental illness that women can experience at any other time in their life, they can also experience in the peripartum, maybe except for dementia, but of course we can also have women with intellectual disabilities who have, particular needs in the peripartum as well. Quickly, just going through the normal transition to parenting. I imagine there are many parents in the room here, and that we all know personally that normal feels very extreme, or can feel very extreme. And I think in our role as medical practitioners, it's important to remember that whenever we're encountering new parents or parents who are, or pregnant women, that there is a lot going on for them. And so we probably need to give them a little bit more of a bandwidth and a little bit more nurturing than we would perhaps otherwise. This is another slide I include often when I do a talk on birth trauma. Which I think, again, is a good reminder for all medical practitioners who are helping women giving birth. Every childbirth is a confrontation with death as well as with life. Modern medicine can now lull us, comfort us, and soothe our terror of personal physical annihilation in most cases of birthing, but not in all. And I think this is just a good reminder, partly about understanding how birth trauma can arise, but also I think in all women who give birth to remember that it may be the most significant and existential experience that they've had. It's certainly, I'd say, if they've grown up in the eastern suburbs of Sydney, obviously that means there's a wide range of people who grow up here. But, if they haven't grown up in a war zone, giving birth might be the closest that they've come to experiencing, a profound fear of death, for example. And that's something to remember. Okay, I think I'll skip over the ghosts in the nursery. Has anyone heard this term before? No. I think it's worthwhile for anyone who's interested in how parents adjust to being parents and what they bring with them from their past. I think it's a really lovely quote. It's by a psychoanalyst back in the 70s, and it's often used in sort of perinatal mental health literature to explain, as I said, that when we become parents, we also carry the generations that went before with us, and that can influence how we perceive our children and how we interact with them. Okay. How comfortable does everybody feel with peripartum depression, with managing it? Sammy? Do you all see a lot of peripartum depression? Is it a common condition you see? Yeah. Okay. So, I mean, I'd expect it would be a common condition because, as this slide says, about 10 to 15% of women who give birth experience peripartum depression. There's a strong overlap with perinatal anxiety, which I imagine all of you would have seen as well. As I mentioned at the beginning, the onset is often in the antepartum. There are known risk factors, so we know what we need to look out for. Untreated, it tends to persist, but conversely, if we get in early, we can often treat it. And it is one of those conditions, as I think in the introduction it was mentioned, that I don't just work in perinatal mental health, I also work in sort of adult psychiatry. And certainly if there's a new onset peripartum depression, then I can usually be fairly confident in saying to the woman, if you have felt okay before, you will feel okay again. Obviously, it depends on the woman, but as I said, if they don't have an experience of that kind of long-term chronic depression, most of them will get better if we treat them. Obviously, another very important part of this slide is the suicide data. So in a setting where maternity care has become increasingly sophisticated and women don't tend to die during childbirth, peripartum depression or psychosis and suicide has become one of the leading causes of death in that period for women. And another reason for us to pay attention to it. Depression in the peripartum is like depression in other settings, except there's a couple of really characteristic features. As I mentioned, often there's significant comorbid anxiety, and often I have the sense that when I treat women, I'm actually treating the anxiety more than I am the depression. For anyone who, is when you're tired at night and you're watching TikToks and you've just been having babies yourself, you've probably been bombarded by celebrities giving accounts of their postpartum depression. I don't know whether anyone fulfills that category, but what's really interesting is when in those accounts, invariably there's a focus on the bonding with the child. And often they will talk about how they were depressed and they just didn't feel any kind of bond. And then since they've recovered, they've got an amazing connection to their child, which of course we can, question to what extent that actually holds true. But it's certainly something that we see in our patients as well. That's a real preoccupation with the attachment and with a sense of being a bad mother, especially because they don't feel those warm feelings they were expecting to feel. The other thing, I'm not sure whether I've included it in the anxiety slides, is the presence of intrusive thoughts. Again, is that something that you've encountered? Yeah, and I think that that's something often that is really important to ask about, because often those are the thoughts that are the most embarrassing. There can be thoughts about, that accidentally dropping the baby, or there can actually be thoughts. I mean, we've had a woman just this week in clinic who's had thoughts about locking her baby in a cupboard or strangling the baby, or, there can be thoughts about inadvertently sexually abusing the baby. And those are really, really distressing thoughts usually that women won't offer up if you haven't specifically asked about intrusive thoughts. Okay, so going back to the management in primary care, I think often a lot of what we do in clinic here is just to do a review of the basics. So There are some things that aren't really commensurate with good mental health. If you're not sleeping at all, if your iron levels are really low, if you're feeling nauseous, 24/7. So again, that's where you guys come in to manage all those other things, and that can often have a really big impact on the mental health. Postpartum, sometimes women are on really intense breastfeeding routines, as I think you've probably also all experienced, where if you actually calculate how much sleep they could be getting, they're probably getting sort of 30 minutes, every couple of hours, which is just, again, not going to be commensurate with good mental health. As I mentioned before, be hopeful, and especially when women come in this sort of acutely decompensated state, they feel as though they will never be the same again, and that's where they really need a medical practitioner or a caregiver to be hopeful on their behalf. I'm just mindful of time. Just before I keep going with these slides, are there any conditions that people are particularly interested in or particularly feel that they need some support with? No? No? Okay, so I'll just keep going. Robbie, if you jump in maybe about 10 minutes. Yeah? Is that right? Okay. The reason I mention psychological treatments here is because we often get caught up in the medication, but actually a lot of our women need psychological therapy as well. And this is probably, I think, a general point to be made, not just for women in the peripartum, but generally, I think it's really worthwhile to know that there are different psychological treatments, and that they're not all as effective as each other. Unfortunately, the way our funding system is structured here in Australia, women or anyone can only get 10 sessions of Medicare rebated therapy with a psychologist. I don't know, does anyone have any views on how effective that would be? Or, sorry?
It's often not really
Yeah. Yeah. And I think especially in the peripartum population, as I said, often attachment is a theme. That's one of the symptoms in depression. And often because there are some attachment-related themes from earlier on in life, and really in 10 sessions, you don't, you're just beginning to build trust. Yeah, if it's all about the therapeutic relationship, it's not going to help you make any lasting change. For things like, panic disorders, or someone who's come in crisis and has a bit of an adjustment disorder and is just getting used to being a parent, 10 sessions could be helpful, basically in terms of giving psychoeducation and some strategies. But I really recommend that you guys become familiar with the psychologists or the psychotherapists in your area, and have a few people up your sleeve whom you can refer to for more intensive therapy. We can provide sort of some resources if anyone needs help with that as well. Okay, that's basically just saying what I said before, that if someone comes to you and they said, I've tried psychology, please ask, because in my experience, they will often say, yeah, I've tried it, didn't work. And I say, well, what did you do? And they say, well, yeah, I had 4 sessions or something. Okay. So medications, how many of you are comfortable with prescribing medications for depression or anxiety in pregnancy? Seeing some nodding. Yes. Yes, everybody, good. This slide is sort of a little bit of the spiel that I give women. So I say to them, the evidence is not as good as we would like it to be. But the available evidence is generally reassuring with respect to, I wouldn't say teratogenesis to the women, I would say, to congenital abnormalities. The evidence of the detrimental impact of untreated depression on mother and baby tends to be viewed as more compelling than the evidence of adverse pregnancy outcomes associated with antidepressant therapy. I'm not sure whether that's something that you also say to your patients. And then sort of the one thing that I do mention, so as not to gloss over everything, is the poor neonatal adaptation. And that it can occur in 10 to 30% of babies, of mothers taking antidepressant therapy. But I explain that it's usually mild, self-limiting, and also that it can be quite non-specific because we use the NAS scoring, so we often don't know whether it's actually the antidepressants or whether it's just an unsettled baby. I posed this question last year for anyone who was here and who was paying attention. Increased, yeah? Everyone say increased? Wow, yes, oh good. Last year we had some decreased, so perhaps maybe it's starting to change. Well, I'm actually involved in a study at the moment which shows, which we're yet to publish, but it has data on prescribing rates for antidepressants in pregnancy and shows sort of a marked decrease just before term. And I wonder whether this is because there used to be, or I think general practitioners maybe in particular, but anyone who was prescribing for women who were pregnant, there used to be the guidelines that said consider ceasing or stopping, which is very much not the guidelines that we have now. Why do we increase it, if anything? Can anyone tell me? Yeah, hemodilution in the trimester, exactly. And also there's not really any evidence that if you decrease it, that there's much less of a risk of poor neonatal adaptation. So what you're then doing is exposing the baby both to the risk of the antidepressant and to the risk of untreated depression and anxiety. So it's very much not what we recommend. In terms of some basic principles, again, usually we start sertraline or escitalopram, but if a woman is stable on another SSRI or SNRI, we don't recommend that you change it. And there are no hard and fast rules. Again, this is something medical students often, or my registrars often ask me, well, who should I put on it? And I basically sort of say, well, it's basically whoever wants to go on it, because there will be women who are very clear about not wanting to start. And then there'll be other women who will be saying, I'm struggling and I really want to start. So they tend to be the women we support. Very occasionally, there'll be a woman who's just not sleeping, not eating. And with those women, I'll really say, I think we should consider this. I think we should give this a go. Yeah. Yeah.
Years prior, like stable for a long
time
on medication.
Yeah.
Is it more worthwhile to potentially start on a medication that they previously tried but were off before they became pregnant, or just go with sertraline and escitalopram?
I'll repeat the question. Okay, I'll just repeat. That's an excellent question. So I've just checked that I got it right. So if someone's in pregnancy and they develop symptoms and they're not on anything. So the question is, do you start them on sertraline or escitalopram, or do you start them on another medication that they've previously been stable on and responded well to? I would probably choose the latter. So I would, if I know that, I think especially in pregnancy where there's obviously a time limit, if I know that there's something else that has worked, as long as it's not, say, sodium valproate, then I would start the other one. Yeah. That would be, so the question was to not, when do you not switch? Is it just during pregnancy or in preconception? And the answer is it would be pregnancy. And if someone is really struggling in pregnancy and they're already on a medication and I just feel it's not working, then I would switch. So it's all about working with that woman, but I wouldn't switch just because I think there's another medication that's safer. Yeah.
Sorry. Online, there is a question about, which SSRIs are safer or less safe in pregnancy, and I think you've answered that. But in that theme, I guess, is there any specific medications pre-conception that you've caught that you would recommend switching prior to actually falling pregnant?
Look, so maybe I didn't answer that. So preconception, if it's not working, I would switch. If it's working, I wouldn't switch. Yeah. Does that make sense? Yeah. Again, unless it's, say, sodium valproate, or there's some medications like agomelatine where there's not really much information on it yet. But I mean, personally, I don't feel agomelatine. I often feel that an SSRI might be more therapeutic anyway. But if someone's happy on, I think say they're happy on agomelatine, I would get them to speak to Mothersafe. But I would, as a psychiatrist who doesn't use it much, I'd probably think, well, are you happy on it because it's working or because you'd be okay off it anyway? And so that was a very specific example. I mean, I guess my general recommendation is if it starts getting complicated, I would get, how many of you use Mothersafe? Yeah. I mean, I use Mothersafe. So if there's anything that's a little bit tricky and you want to keep the patient on it, then I would call Mothersafe, get them to call Mothersafe. If there are sort of therapeutically questions, say they're on, something like agomelatine and they need to be switched over, if they're birthing here at the Royal, you can always refer them here. This is a little plug for our service. This is a little bit going off the topic, but certainly any women you have who have some mental health vulnerabilities, I would recommend, even if they have private health insurance, hopefully I won't get in trouble from their private hospitals, I would recommend that they deliver here because they have access to our service if they deliver here. And it's a free service. We can see them antepartum and up to 1 year postpartum if they live in area, and all the complicated kind of medication switching we will do for you if you'd like us to. I think that's a question I had last year as well. I'll just repeat it. Can women be referred to us pre-conception? Look, we don't yet have a preconception clinic, but if you have really complicated women, especially if they're women who will have been involved with our gynecology team, for example, then you can certainly try sending us a referral, and chances are we'll take them. But we don't have a designated preconception clinic at this stage. It may still come. Yeah. Okay, we might just move, because I'm mindful of time. Anxiety is pretty much the same as depression in terms of management. I guess with bipolar disorder, it's a little bit more complicated. Does anyone know what sort of the major, what is the thing we're really concerned about if a woman has a diagnosis of bipolar disorder? Sorry? Yes, but I mean, yes, but in what context? Yeah. Psychosis, yes. So they're at much higher risk of postpartum psychosis. Do you know whether that's the case for bipolar 1 and bipolar 2? Yeah, I've kind of put it in this slide. Yeah, so it's bipolar 1. So if they've had a previous manic episode, so I think it's if someone has been diagnosed with bipolar, it's unfortunately we had a phase, I think, in psychiatry of overdiagnosing bipolar 2, which meant that a lot of people who perhaps had other things going on, so for example, personality disorder were diagnosed with bipolar 2. In the peripartum, that makes it really tricky because women who've had proper full-blown manic episodes who've been, say, admitted to hospital, they are at a significantly higher risk of postpartum psychosis, which carries, I don't know whether anyone's seen postpartum psychosis here, carries a lot of risk to the woman and to the baby. If they have a diagnosis of bipolar 2, that, and especially if it's perhaps more of personality vulnerabilities or, sometimes teenagers are diagnosed with bipolar 2 and they're just teenagers. And they can sometimes be on a really complex array of medications that they actually don't need to be on. So I often recommend that if someone's had a diagnosis of bipolar, you try and refer them to a psychiatrist so that you're not left trying to wade through, does this person really need to be on medication and on medication that potentially is risky, or, could I actually try and get her off? So, for example, I had one woman who'd been diagnosed with bipolar who was on 300 milligrams of lamotrigine and 400 milligrams of quetiapine, and was a public servant. I'm not sure how she was functioning with 400 milligrams of quetiapine, but we actually bit by bit, because of the pregnancy, managed to get her down and completely off all medication by the time we discharged her sort of 1 year postpartum. So that was, a happy ending story, but it's something that you wouldn't necessarily want to do yourselves, I suspect. Okay, I might just move over to Robbie to give some more.
Sorry, just in terms of medications, there was an online question about what happens to patients who are on ADHD medications, whether that's preconception or falls pregnant.
So ADHD is a great question because obviously that's also an increasing population. What we always, I guess, we kind of unfortunately evade the question a little bit here at the Royal because we don't prescribe the stimulants ourselves. So they always have to be prescribed by a private psychiatrist. I don't know whether any GPs here are prescribing it. And so we, our general advice tends to be speak to MotherSafe. I would, if you had a patient on stimulant medication who was in preconception, I would get them to speak to MotherSafe. I don't know whether you all know that it's not just a phone line, you can also get the patient to book in with the clinical geneticist, and that's what I would recommend. So they're going to do that. If they're full and pregnant, same thing. So it's not an absolute, you can't be on stimulants, but it's a little bit more nuanced around, the risks and benefits and the amount of data that are available. So it's something that I would get them to really think about, thoroughly. Okay. Robbie, did you want to?
Hello, I'm Robbie, and I was just going to give an overview of our service. So you've met Meredith now, and so our team consists of psychiatrists, Dr. Anne-Marie Rees, Mondays, Vanessa Crawford, Tuesday and Wednesday, and Dr. Meredith Stone, Thursday and Friday. Dr. Will Coleman's our current psychiatry registrar, and we have 6 monthly rotations. So we have a registrar every 6 months doing their training. They're usually in around 4th year, 5th year, usually at the end of their training. And then I'm the perinatal mental health midwife consultant. And we have an outreach team, perinatal mental health outreach service through the Royal. That's Molly Bryant and Leona Ryan Doyle. Molly's a social worker and Leona's a child and family health nurse with mental health training. And then we have, fortunately, 3 psychologists, 3 clin psychs, and they are 1 full-time equivalent. Amelia, Sarah and Teresa, they all work part-time, and a couple of them are in private practice as well. So they make up a full 1 psychologist for us, and they've often got a wait list. Just at the moment, there's some availability, but we went from a 3-month wait list until Teresa came back from mat leave, and we all went, yay, and we got women onto the program. They see women in the local area up to a year postpartum and through the pregnancy. And so there's no defined amount of sessions, and they tend to do weekly or fortnightly sessions. So they usually start off weekly. So they've got quite a long therapeutic engagement with the woman. So that's just reiterating our service. Our psychiatry clinic is available Monday to Friday. And referrals are at the moment we're transitioning from paper referrals to e-referrals. And so I usually triage the e-referrals and refer on to our psychiatry or see what the woman's needs are. So our psychologists, the referrals are in-house usually. But if they've seen one of our psychiatrists or they've seen myself, social work also refer. So it depends if you've referred a woman in or if you know a woman's being seen by one of us, then they are eligible if they live in the local area and they've booked here or they've birthed at the Royal Women's. The outreach team, they pick up referrals in-house as well. So usually I'm the first point of contact. I triage women from their booking visit when their midwives do their full psychosocial history. They come along to our triage meeting. I triage with the social work manager and then allocate the women to our service or to social work. And the outreach team pick them up if they've seen psychiatry or if we think they're going to have vulnerabilities, especially postpartum. They see women up to a year after they've birthed and they go into their home, so their home visits. And the more vulnerable women, they do a lot of attachment work with the baby and mum, and they support the women's mental health. So this our service is based on the Safe Start guidelines. They're in the process of being updated this year. They should be out by about July 26. They haven't been updated for a while, but at the moment they're our guidelines for early intervention. The women are screened, assessed and referred at booking, and trauma-informed women-centred approach from the Safe Start guidelines. And then the Child and Family Health pick them up afterwards, as well as GPs. So our referral pathways, we have our weekly triage meeting. That's myself and social work. And as I said, we refer to social work, perinatal mental health, or back to the midwife, so the midwife can monitor. And so they're monitored by midwives, their GPs. We have, we also refer them to our Becoming Amazing Mothers group if they have a history of childhood trauma, and that includes childhood sexual abuse. And our Becoming Amazing Mothers group runs 6 weeks antenatally and 6 weeks postnatally. It's run by a senior social worker, and she's a consultant, and she runs, I think, about a group of 8 to 10 women, and they get a lot of benefit out of the program. It's psychoeducation, but they also work with her to move forward, and how they can make a better parenting story with their fears of what's happened to them in the past and how they can make changes, and also what might come up for them during the pregnancy and the birth and becoming a parent. Then we also have a weekly multidisciplinary Safe Start interprofessional meeting, which we have a psychiatrist, myself, outreach, psychology, SUPs attend our meeting, social work, midwifery managers, and the local Eastern Suburbs Mental Health PIMS team. So any complex women or cases or anyone we're concerned about in any way, shape or form, we discuss at that weekly Wednesday meeting as a multidisciplinary group. And so the different services, different facilities. So the difference between PIMS and POMS, which even acute care team and the mental health line have a lot of trouble working out, and our midwives as well, and our doctors. So POMS at Perinatal Outreach Mental Health, they are part of our Royal Women's Service. They're a part of our team, and the woman needs to be booked at the Royal Women's, birthed at Royal Women's, be in the local Eastern Suburbs area up to kind of South Darling Streets and all of St Vincent's area, just not Sydney local health. And they have moderate to high mental health risks. They have an attachment focus. And sorry, I'm talking about POMS. And they're up to a year. So I think I've put my slides in the wrong. The top one was POMS. They're up to a year post-birth. So even if somebody gets referred in at 3 months postpartum, they see our psychiatrist, then we think, oh, they'd be great for our team to go and keep visiting. Then, apologies, I've swapped them around, but PIMS is very different. It's Prince of Wales Eastern Suburbs Mental Health, based at Prince of Wales. For women in PIMS, they can birth anywhere. So if they birth at the private, the Mater, but they live in the Eastern Suburbs local area, then they can be referred to PIMS. They just don't cover the St Vincent's area. So Port Paddington and Darlinghurst don't get a look in for PIMS. And that's why we extended our outreach service to that area. So they take a more medium to high severe mental health risk. They may have already been linked with mental health, have previous hospitalisations. They're referred during pregnancy or postpartum, and they have a weekly intake meeting. The referrals can be 0 to 2 years via the mental health line. I'm going to have to swap those around because that's going to be confusing. So they're different services, but we're sister services and we attend each other's meetings and we have a lot of collaboration. There's just a bit of difference. So our work is to minimise impacts on the baby, the social, emotional, cognitive and behavioural development of the baby. And so to do this, the treatment of the anxiety and depression, the attachment interventions and psychoeducation, etc., and sending them off to courses like Circle of Security. We work very closely with our social work department, and they don't do postpartum work, but they take referrals during the whole pregnancy. So they're the population with complex relationship issues, loss and bereavement, domestic violence, housing, legal issues, DCJ and child protection issues, which sometimes cross over with our service, and drug and alcohol. We have our SUPS team. So we work closely with the SUPS team as well. So we're kind of always in each other's offices discussing who's doing what and what we can do for the women. So we collaborate very closely. This is the Becoming Amazing Mothers group, the one that Beverly runs, and then any questions, just an overview of the service. Any questions before we do either of us?
Yep.
Yes, forgot about that. It's our birth reflection service that yes. So I'm one of the senior midwives who work on the.
Put the question in again.
Oh, sorry, the question. So related to birth trauma, our debrief service, and does that link with our mental health service? If one of us who sees the woman for the birth reflection think that there's worries or concerns for her mental health, the pathway is usually to get in touch with me, and then I do an assessment of what's going on, and then I'll refer on to our team if it's relevant. Yeah, for sure. Yeah.
Access the psychology service.
Yeah, and psychology and psychiatry, and outreach. Yeah.
Trauma, like not at the time maybe, but
yeah. You could do an e-referral, call our service. Yeah, you can do an e-referral but specify what you're concerned about, because it might just go straight to psychiatry. But if it's more of a birth trauma concern, then I'll be picking up the referrals and I can refer her to the appropriate service. Yeah. There is a QR code and a referral pathway for birth reflections. Yeah.
Sorry, I'll just add that question was about how to go about referring if it was quite a bit later on after the actual birth itself. But yeah, so please still refer.
I just have a quick question for you guys. Obviously, there's been a couple of questions on birth trauma and there's been quite a lot in the media recently. Would you find it helpful to have a session just on birth trauma? Is that something? Yeah, so we could maybe do that maybe next year.
Or in November.
Oh, okay. No, I'll just find myself up.
Sorry, just a quick question from up here. Sorry. Thank you. That was very helpful. Looking at your team, do you have an Aboriginal health worker on your team?
Our social work have got an Aboriginal health worker, and we work closely with Malabar midwives, and the Child and Family Health have an Aboriginal health worker, but our team specifically don't, but social work have one, yeah. Yeah, we just certainly link them into the appropriate people. Yeah.
Yeah, I mean, often our Aboriginal patients come through the social work team, and so they've sort of accessed that, and then if they feel that they need us sort of on top of everything else, then they get referred by them, and usually that works quite well. Yeah. So you recommend Yeah. In the first instance, because they can often do that sort of liaison, or if they're already linked with Malabar midwives, they can then refer to us. But of course, we can take direct referrals, but just in terms of making it feel more culturally safe. Yeah.
Just repeating, that question was about if it was an Indigenous patient, potentially you should just refer through social work first, and then they can divert from there. I think that's it. It's been a long day, so thank you guys for presenting so lovely. And also thank you to everyone who's attending both in person and online.